Okay, guys, we're gonna go ahead and get started. I'm going to go through some housekeeping with you really quick. Oh, there we go. Okay. If you had not yet, this is our sign-in QR code. They're also over at the registration desk, but we just like everybody to sign in. So I'll pause for a moment. Don't see anyone. Good. Okay. The next one is pre-test. This would be if you're claiming credit. You want to make sure that you complete the pre-test. So I'm pausing to see if anyone's taking photos. You good? All right. Here are our faculty for today, not in order, they're in alphabetical order, not in order of presentations. We have Dr. Gotti, Dr. Jane, Dr. Maraca, and our first presenter will be Dr. Weinberg. Here are their disclosures. The disclosures are also posted on the website. If you go to CME RCP and click on the summer series, under accreditation, you can look at a full list of all of the disclosures. In the program handout, so this is redundant, I just like to point it out. We've got our target audience, learning objectives, and our agenda for the day. Thank you to our sponsors and exhibitors. And that does it. So, BK.
Welcome, everyone. Thank you again for being here and present. And so those who are watching virtually, also welcome. It's my pleasure to bring up our first speaker, Dr. Frank Weinberg. Yeah. Tell a couple more about Frank for a second. So Frank was one of the first people I had the pleasure of hiring. I was really trying to set the bar very low so that every other hire would be great. Unfortunately, it's way up here, so it's been very hard to keep it up. But just an exceptional clinician. I get to see him in action all the time in clinic, just caring, thoughtful, and just people saying wonderful things about him. But on top of that, he's a scholar of the nth degree. Frank, just to give you an idea of his scholarship, some of us have MD PhDs, and what we do is we combine the degrees and do them at the same time, to do it faster. Not Frank. He did a full PhD and then went back and got a full MD. Just gives you an idea of the commitment to education and scholarship. Frank's research is really unique. He actually is focused not on just social determinants of health and how they contribute to health inequity, but how they biologically contribute to differences that we see in outcomes for various diseases, with an emphasis, of course, on small cell lung cancer and non-small cell lung cancer. He leads our lung cancer working group. He's a thought leader in the space nationally now as well. Just couldn't be more proud and happy to have Frank as my colleague today.
That's really nice. That's a really nice intro. So I appreciate that.
255.
So, I'm frequently asked this time of year, why are you so freaking stressed? Whether it be my wife, my kids, my patients, my colleagues at work, and I usually the answer is because of this meeting, So today, I'm going to take some of the stress out of it for everyone else, hopefully, and go over some of the most pertinent, I think, most important studies as it relates to lung cancer from this year's ASCO. So we'll just jump right into it. So small cell lung cancer continues to be last year and this year, kind of the most interesting studies really are coming out of this field, in my opinion, the thoracic space. And so, we'll start with this interesting abstract, the Achilles trial, which is similar to Adriatic. If you're, familiar with last year's ASCO, you'll remember that in limited stage small cell lung cancer, for a long time, the standard of care was chemoradiation, followed by basically observation. But last year, the Adriatic trial came out, and basically a new standard was set. That is, you do the chemoradiation followed by durvalumab consolidation, right? And so this year we have the Achilles trial, which looked at atezolizumab instead of durvalumab in the maintenance setting. This was actually a negative study. So if you look at progression-free survival and overall survival, there wasn't significant benefit to atezolizumab in this setting. So, it's interesting, you can see no statistical significance in studies. If we demonstrate, the Adriatic data from a year ago, you'll see, clearly there was a progression-free survival and an overall survival benefit. We still are trying to understand why exactly we don't see the signal in the patients who were treated in atezolizumab. I think a lot more data will kind of come out. Subgroup analysis from the Achilles trial will be interesting to kind of look to see, are there certain patients that actually did benefit and who isn't benefiting from the atezolizumab? And what is it about atezolizumab that potentially is different than durvalumab? We're always thinking that these things are all kind of Coke and Pepsi, but are they really? Depending on what type of cancer setting you're in. So that remains to be seen. So I think durvalumab maintenance continues to be sort of the standard of care for limited stage small cell lung cancer, in patients who are definitively treated with chemoradiation. So let's turn now to extensive stage small cell lung cancer. So this is the current treatment landscape. I thought Dr. Kaplan, who did the discussion on this during the plenary, did an excellent job of kind of capturing where we are and where we're going. So first line therapy for extensive stage small cell lung cancer continues to be chemoimmunotherapy based on the Power 133 or the Cascade study. That is platinum-based chemotherapy with etoposide combined with an immunotherapy agent, either atezolizumab or durvalumab. And then that's continued as long as there's no progression after induction to immunotherapy maintenance. Upon progression or toxicity, there are second-line options, which are topotecan, lurbinectedin, and tarlatamab. I think the key questions were exactly what she asked, right? How do we improve first-line treatment in this space? We know that this space is still the goal of treatment, even with all the new agents coming out in this space, is still palliation, right? We know most patients are still going to pass from this really aggressive disease. And also, when should we be giving our DLL3 therapies? I think we got some insight to this. We'll go over some of the data that was presented at the ASCO session this year. I think we kind of have an answer to that. And then biomarker-driven therapy. I can't tell you how important that's going to be in this space. And we're lagging where we are in the non-small cell lung cancer space in terms of understanding how biomarkers play a role in the small cell lung cancer setting. So the Delphi 304 study, this abstract was presented this year. It was the overall survival data, which was a secondary endpoint, or it was a primary endpoint from this study. And so this study was basically a study that was designed for histologically confirmed extensive stage small cell lung cancer after progression on first-line platinum-based chemotherapy with or without immunotherapy. So just to take you back a year ago, the 301 study, Delphi 301, was basically a study that looked at all lines of second line and above. And a lot of those patients were third or fourth line treatment. So this study is specifically looking at second line only patients. So, basically these patients were randomized 1-to-1 to receive tarlatamab or chemotherapy. You can see here, topotecan, that's, 185 patients received topotecan, 47 received lurbinectedin, 23 amrubicin, that's probably our Japanese or the Asian cohort. And so, Delphi 304 did meet its primary endpoint with tarlatamab demonstrating superior overall survival over chemotherapy. And you can see its impressive data in this space. At 12 months, 53% of patients were still alive if they received tarlatamab versus 37% in the patients who received chemotherapy. The median overall survival was 13.6 months in the tarlatamab arm versus 8.3 months. And this was statistically significant. So this was a positive study. And there was a different type of toxicity profile. We talk in the extensive stage space all the time about the fact that not only are we looking at efficacy with these agents, but we also want to look at, how do the patients live better, longer, right? That's what I always say, especially in the small cell lung cancer space. And you can see here that tarlatamab, while it has certainly adverse events, these adverse events are different than what we had seen with chemotherapy, right? Whereas chemotherapy, we see all the things, GI toxicity, myelosuppression. With tarlatamab, we're really seeing sort of new sort of side effects, different set of adverse events, primarily cytokine release syndrome, which remains mild in general, less than grade 3 for the majority of patients. Dysgeusia, that has to do with the fact that the DLL3 receptor is also on your taste buds, so that's why there's effects on how you're tasting with tarlatamab, decreased appetite, those sort of things. But a lot of the myelosuppression and the GI toxicity that can be so debilitating for patients in the second line setting, we don't see with the tarlatamab. So I think this is pretty much confirms that tarlatamab should be sort of the recommended or preferred second line option. We'll wait to see what the guidelines committee and whatnot recommend. It's already approved in the second line space. So for me, I'm pulling tarlatamab for a patient that, as long as the patient's able to receive it in the extensive stage setting after progression on first line therapy. The other interesting study that in the small cell lung cancer space was the Forte study. This was an interesting study looking at sort of maintenance first line treatment. And so this study kind of recruited patients. You can either enroll prior to induction chemoimmunotherapy, or you could enroll after induction chemoimmunotherapy, so long as you had an ongoing complete response or partial response or stable disease. And then you were randomized basically to lurbinectedin and atezolizumab versus standard of care atezolizumab maintenance alone. Patients were treated until progression of disease or unacceptable toxicity. And the key is that no crossover is allowed. And the primary endpoints were PFS and OS. And what we see is that PFS from randomization into the maintenance phase, there was a significant improvement in progression-free survival. At 1 year, 20.5% of patients treated with lurbinectedin and atezo versus 12% in the atezo only arm. And this correlated to a median progression-free survival of 5.4 months versus 2.1 months. I want to just I know this is a busy slide, so focus first on the overall survival, right? That's from randomization into maintenance phase, okay? So we have to remember in the study, it didn't include induction. So right off when I'm looking at the data, I'm adding about 3.2 months, which is the standard induction treatment, right? So we look at the numbers, right? We see that, the lurbinectedin atezolizumab arm, we look at the median overall survival, it's 13.2 months. I add 3 months to that, it's about 16 months, right? Key is looking at your control arm here. So the atezo only arm, how did that do? So 10 months, right? Median overall survival, but we add 3 to that, that's 13. Then we look at the Empower 133 data, right? Which is over there on the right side of the screen, up in the right-hand corner. And that shows, can't really see it, but it's about 12 months overall median overall survival in Empower. So right there, you know that your control arms are doing well. So you can potentially start to think about comparing these studies, right? The control arms are performing about the same, right? We always talk about not doing cross-trial comparisons, but when you have nothing else to compare to, this is how I do it. If you look down below, because before, the standard of care is basically to do your induction chemoimmunotherapy and follow that up on progression with a second line option like lurbinectedin. So if you look at the sequencing, and then this down here on the right-hand corner, in the lower right-hand corner, is the results of the basket trial that kind of led to lurbinectedin's approval, right? And this was a basket trial of all tumors, but this subgroup analysis focused on non-small cell lung cancer. And when you look at the median progression-free survival, this is all in second line lurbinectedin. or in the overall survival, my bad, and you see a 9.3 month overall survival advantage. So if we start to compare the two regimens, we look up above, we look at induction chemotherapy, about 3.5 months. You combine that with maintenance lurbinectedin plus atezolizumab, that's 13.2 months, for a total of 16.4 months, right? Below is kind of how we were practicing for, which is, basically induction with chemoimmunotherapy followed by immunotherapy maintenance. That's on average about 12.5 months, right? Overall survival. And then on progression, patients receive potentially lurbinectedin. That's another 9.3. You're looking at 21 months. So is it actually better to put everybody on this more probably toxic regimen? We don't know, right? But I think what comes out of this, the two take homes from, I think, this abstract was that number one, lurbinectedin performs well in the first lines setting. So is lurbinectedin potentially, can that be utilized in the first line study? Could that be utilized in induction? Could that be utilized in combinations with other novel agents to improve overall survival in the first line setting? I think they've set themselves up nicely for that. But I think it also kind of comes to the point of looking at subgroup analysis. Who actually does need to benefit from this more aggressive approach, from the two-drug regimen and maintenance setting? I'm sure there are patients, obviously, that are going to benefit from this. Who actually needs it and who actually is not going to benefit from that? So is there a specific, small cell lung cancer subtype, ctDNA positivity? Could that be used as a way to kind of escalate? And could this be your escalation regimen if you have ctDNA positivity after you go through induction chemoimmunotherapy? Potentially, right? So I think a lot remains to be kind of hashed out from this, but I think this was an exciting study because, again, it's showing that a medication, certainly lurbinectedin compared to standard doublet chemotherapy, I would say is better tolerated by patients, less toxic in general. So putting it in the first line setting, I think that's the most exciting thing. And I hope that companies will invest and do these studies moving forward with lurbinectedin as sort of a backbone combination strategy. All right, so here's where we stand in terms of the current landscape after this ASCO. I think chemoimmunotherapy, maybe plus or minus lurbinectedin, depending on which patients we think might benefit from that regimen. And then second line therapy, I think, is tarlatamab. And then you have your third line therapies. All right, so let's turn and talk a little bit about early stage non-small cell lung cancer. So I think, one of the great things to see was all, over the past couple of years, we've seen the neoadjuvant space, the perioperative space in lung cancer really explode, right? But we honestly, a lot of our data has lacked overall survival. And this was Checkmate 816, is the first neoadjuvant study in the early stage space to show an overall survival advantage, which I think is really important. So for this study, again, 816, the key eligibility, a newly diagnosed or resectable stage 1B that's less or greater than or equal to 4 centimeter tumor, to 3A, non-small cell lung cancer. And then good performance status, and of course, no GFR alterations. They were randomized to receive nivolumab plus standard chemotherapy versus chemotherapy alone. After they received those 3 cycles, they were restaged and then went to surgery. And there was an optional adjuvant chemo and or radiation that could be used after surgery. So here's the final overall survival analysis with neoadjuvant nivolumab and chemotherapy versus chemotherapy alone. At 5 years, 60 months, 65% versus 55%. The median overall survival is not reached in the chemoimmunotherapy arm, 73 months in the chemotherapy arm. So this, again, kind of, brings home the fact that this regimen will lead to overall survival, and we should be practicing at least, a perioperative neoadjuvant approach to these early stage patients. I think what's also interesting is that they did a lot on kind of understanding overall survival by ctDNA clearance status, which they've done a ton in the GI space, right? Colon cancer, rectal cancer, but not so much in lung because they're kind of new to the neoadjuvant perioperative space. I think this is interesting data. I mean, I think if you look at that top green line, which is the nivolumab chemotherapy line, patients have ctDNA clearance. You're looking at 75% of patients with an overall survival at 5 years. If they don't clear their ctDNA, you can see that's 53%. So, I think that ctDNA is going to become really important in this space in kind of helping us understand, who may need more or less treatment in the future. Are we going to get to a point where we can kind of say, maybe this patient doesn't need surgery? I don't know. Maybe someday, but at least we can get to the point where maybe we can say, maybe this patient doesn't need adjuvant therapy. Maybe we can watch this patient instead. Or maybe we're going to say, hey, this patient needs adjuvant therapy. And these biomarkers like ctDNA will, I think, help us understand who needs more or less treatment. So neoadjuvant nivolumab with chemotherapy, it demonstrates a clear overall survival benefit in stage 2 and 3 resected non-small cell lung cancer space. I think ctDNA biomarkers to determine who actually needs adjuvant treatment will come out of this. The NeoAdora trial, now changing, kind of focusing on the targeted molecular space, was an interesting study, phase 3, looking at patients with resectable EGFR mutated stage 2 to 3B non-small cell lung cancer, basically randomized to either receive osimertinib with chemotherapy or osimertinib alone, or placebo chemotherapy. And they received this for 3 cycles or 9 weeks, and then went to surgery. And then the primary endpoint was major pathologic response, with secondary endpoints being event-free survival, pathologic complete response, and nodal downstage. And there was a controversy about whether or not major pathological response is the right primary endpoint for this study, right? Because a lot of these studies, as you all seen, they focus on event-free survival or pathological response. So this is a little unique in that it's looking at major pathological response instead. I think, based on that data, both osimertinib containing regimens showed a statistically significant benefit in the major pathological response rate compared to chemotherapy alone, placebo arm. And then if you look at the very immature EFS data, you can see that already we're starting to see, that the osimertinib combinations probably are going to be performing better than the chemotherapy alone. I just want to bring out the point that right now, the way that we practice in this space is really based on taking patients up front to resection if they can, and then following with adjuvant osimertinib based on basically the ADORA trial, which is on the right-hand side here. And you can see, what we're looking at in terms of overall survival with the ADORA trial. Will we see that with the neoadjuvant approach? I don't know. I mean, we certainly are probably going to downstage a certain number of patients who are more advanced, the stage 3 patients, and potentially that's going to yield better outcomes. But I don't know if the neoadjuvant approach is going to trump the adjuvant approach. So I think, the neoadjuvant osimertinib chemotherapy combination appears to show benefit in event-free survival. We'll need to wait, obviously, for the mature data. It was interesting because they have those 2 arms, osimertinib plus osimertinib and chemotherapy. Potentially, I could downstage patients with just osimertinib alone. That would be great. It's way better tolerated than, adding chemotherapy in there. So that might be an interesting prospect in the future to see how that osimertinib arm actually performs in mature data. And then obviously there's the case for biomarkers in how we utilize neoadjuvant. Is EGFR mutant cancer that also has a P53 mutation? We know those are more aggressive cancers. They tend to progress, tend to recur more frequently. Is that a case where we might be thinking, okay, let's maybe utilize the neoadjuvant approach? So a lot more to come out of this space. All right. And then, in terms of late stage non-small cell lung cancer, I think this was an interesting study. This was one we had open at UIC, actually, the Pragmatica study, which was a really, interesting study design. It was a very limited eligibility criteria, which I think in the end, this is a negative study. I think in the end may have hurt them a bit because their population probably was so heterogeneous that potentially they didn't see a signal because, you know, they had so many patients of all different rhyme and reason involved in the study. But either way, these are patients that were previously treated for stage 4 recurrent non-small cell lung cancer. They were randomized to get standard of care, basically investigator's choice chemotherapy versus ramucirumab, which is a VEGF inhibitor, and pembrolizumab. And you can see here, I applaud them on their demographics, right? I mean, I haven't seen a study that's enrolled over 10% Black patients in the thoracic space. I don't think ever. So, I mean, that's great. You know, also, you know, borderline performance statuses were included. You know, all different types of lines of therapy were included, but I think this probably muddied the water in the sense of trying to understand, you know, whether or not there was actually benefit to this regimen. And I think the numbers are low here, but hopefully we'll get some with the more investigative subgroup analysis that I'm assuming they're doing. We'll understand better, you know, where the signal might be in these patients. So you can see here the overall survival. It was a negative study, no benefit to overall survival with the ramucirumab and the pembrolizumab. But interestingly, if you look at non-squamous and squamous, for example, while the squamous you still see not reaching statistical significance, is there a trend there? We know that, you know, at UIC, we have a study combining cabozantinib in the maintenance study, first line with pembrolizumab in squamous cell patients. Potentially, is that where these sort of VEGF inhibitors might do better? Remains to be seen. So ramucirumab and pembrolizumab does not improve overall survival in second line and above metastatic non-small cell lung cancer space. I think it'll be interesting to actually see if there is a benefit in the squamous cell. Okay, and then this was a very interesting study. I think one of the most interesting studies from all this, because this has real ramifications on clinical. So this was a study where the authors looked at basically time of day that immunochemotherapy was given to patients with advanced non-small cell lung cancer. We know that circadian rhythms can play and impact disease and therapy, right? Preclinical studies have shown that there's association with circadian rhythms and immune cell function, and this may impact the efficacy of immunotherapy. There's 20 retrospective studies, there's meta-analysis, all looking at sort of when immunotherapy is given, and most have shown that, you know, if you give it earlier, patients do better, right? This is the first prospective randomized phase 3 study looking at basically early, before 3 o'clock or late after 3 o'clock, infusion of chemoimmunotherapy in patients with advanced non-small cell lung cancer. Here's the study design. Again, advanced non-small cell lung cancer, randomized to the early treatment group versus the late treatment group, and progression-free survival was the primary endpoint. And you can see here, this was a very positive study. You look at that hazard ratio, 0.42. Median progression-free survival, 11.3 months in the early group versus 5.7 months in the late group, right? You look like the PFS, you know, if you look at subgroup analysis, all levels of PD-L1 expression didn't matter. These patients all pretty much benefited from therapy, early therapy. Overall survival, the same thing. The median overall survival in the early group wasn't reached versus 16 months in the late group. And I think what's really interesting is they actually did some biology here, and Kate told you that I do a recessive PhD, so I always like a little bit of biology in my clinical studies. I think that goes a long way. And here, this is interesting data because it actually shows that in the early group, you actually have more circulating CD8 positive T cells. These are the cells obviously that respond to immunotherapy and target tumors, right? There is more of those circulating in the early group. In the late stage group, in the late treatment group, there are more CD4 positive T cells or immunosuppressive T cells. And then they looked at activated T cells versus exhausted T cells and found too that in the early group, you have more activated T cells. These are T cells that are actually going to respond versus in the late group, you have more exhausted T cells. Those are T cells that are there, but they can't respond to the immunotherapy. So I think, should we be trying to prioritize immunotherapy infusions for the morning? Probably yes. That has all sorts of logistical issues. And I'm sorry if there's an infusion nurse in the audience, but their data shows that potentially this is a better way and an improvement in the overall survival of the patients. I think it will be interesting to understand the circulating cytokines and immune cells that help us develop synergistic therapies. What is it about patients that are treated earlier? What is it about earlier in the day? What are our immune systems doing, right? Understanding our baseline immune systems in the morning might lead to next generation combination, novel combination approaches. All right, so this is a summary of everything that I kind of talked about. And then I'll just say thank you for watching, and I'll take any questions.
Thanks, Frank. And microphones are going out if anybody has a question. I have the first one, get the moderator. Yeah. So in the time of day study, they gave immunotherapy and chemotherapy in the morning. How do you know it's not the chemotherapy that's driving the difference and have a reason to follow?
It could be, but I think, if you look at the biology, the CD8 cells, they're, the fact that there are more CD8 cells circulating probably means that the immunotherapy is going to work better in the morning, right? Compared to, the late stage or the later treated patients who have more exhausted T cells, which just aren't going to respond to immunotherapy. So I don't know if chemotherapy, it might be that chemotherapy works better in the morning too.
There's an older literature on that. Actually, beta-adrenergic drive in the morning is different than the evening, and the immune system is vulnerable to this. But the chemotherapy, obviously, when you infuse it, it gets in the system, it clears. Immunotherapy gets in the system and it stays. So that's why I'm curious. And if we switch to subcutaneous immunotherapy, it's kind of in your system slowly. So I'm just curious. It's interesting. Yeah. I'm happy to take any questions from the audience at this point. Did I ask the one good question?
Can you guys repeat that?
The question is about whether or not the timing of immunotherapy applies to other disease states. From a biological perspective, I would say it probably does. Be interesting to see what prospective studies in other disease states too. Thank you, guys.
Just so you know, Frank wakes up at 4 in the morning. He swims for like an hour or 5 minutes. He's got the best immune system in the audience. So it's my pleasure now to invite Dr. Stefani Moroccan, who's going to give us updates on neuro-oncology. This is not a space we often incorporate. I've had the pleasure of getting to know Dr. Morocco over the last 5 years. We're collaborators, we work together, and we actually provide care together for patients who have sarcoma and neurologic diseases and complications related to, but also presentations within the nervous system of sarcoma. It's been a great pleasure to work with you. Prior to joining us, she was a fellow at MD Anderson, and I think you came in 2018, is that right? Yeah, 2018. So we're looking forward to this update.
Thank you for the kind introduction, and thank you for giving me the opportunity to talk to you about brain meds today. I apologize for my voice will go in and out. It's a pleasant gift for my kids that ran out of the cold the last couple months. So we'll talk about CNS meds. Here. It's gonna drag cell. Okay. the green and red area. So we'll talk about CNS meds, of what we know so far and how we have moved it forward. I have to say, the neurobiology is screening also primary brain tumors. I'm very enthusiastic of looking at data for brain meds. And I'm hopeful that, primary brain tumors also will follow this enthusiastic innovations over the last 10 years or so. So those are my disclosures. Hopefully today we'll learn how we're managing currently the brain meds and LMD and what are the future directions. It's been divided from those two big categories of the CNS meds. As we know, it's the most common malignant tumor in adults, with lung and breast being the most frequent primary tumors in general primary malignancies, and melanoma has a higher predilection for brain meds. And we now know that, except of stage of diagnosis, we now have all of these risk factors for brain meds that are being driven from molecular background, with breast cancer having HER2 positive disease, having higher risk for brain meds. Around 50% of those patients will have brain meds. Triple negative and also BRCA1, BRCA2 germline mutations are those patients are high risk of developing brain meds. In the lung, EGFR mutant patients also have high risk for brain meds, etc. So when we are approaching those patients, those are the categories of treatment approaches: as surgery, radiation, systemic treatment. And we have to remember also the supportive symptomatic management of those patients with symptomatic edema, steroids, seizures that comes from the neuro background, that we have to support them along the way to have good quality of life. For surgery, it has been established many years now that the role of surgery is to first sometimes establish diagnosis. We might have the only area of the brain being able to have tissue from, but also we know that there are survival data for patients with solitary brain met that has been established from back in the 90s when you compare surgery or surgery with whole brain radiation, that we had survival benefit adding the surgery. And when we have multiple brain meds and we have one that's very symptomatic, not so much supported from survival, but from alleviation of symptoms and improvement of quality of life for those patients. New surgical now processes thankfully have been established. So laser interstitial chemotherapy are one of them, which is a probe that with a bar hole you're applying increased temperature there, you calculate the area. And there are many now prospective studies that have been established their role. With a meta-analysis being published this year, having median overall survival across studies of 14.4 months. And now we know that also the combination of lead with SRS also improves survival of those patients compared to just do lead alone. So lead followed by SRS is also a good treatment option. It's really helpful that lead when we're coming in the era of recurrent brain mets after radiation, that we have limited options. And also it's beneficial for radiation necrosis too. So sometimes you are dealing with this dual effect of you don't know if it's a regrowth or if it's radiation necrosis, and it can work for both and also gives the benefit of biopsy those patients. Radiation treatment, all traditional whole brain radiation, SRS, and now brachytherapy. We're trying to understand the role of brachytherapy to brain mets itself. SRS, we know that pre-op or post-op SRS, we'll talk a little bit about post-op SRS in a while, improves local control of those patients. And now there are many studies, clinical trials that RADOC folks trying to understand how many brain mets they can safely radiate and omit the whole brain radiation. And at ASCO this year was published a study from Dr. Russell et al. That irradiated up to 20 brain mets that deemed that had the same effectiveness as whole brain radiation and being safe. If we're gonna elect to do post-op SRS, now there are supportive studies that you have to do it within a month. It seems that it improves the rates of recurrence if you would do it within this month after surgery. There's a lot of discussion now in the field of doing actually pre-op SRS that has really changed the last couple of years. And that's something that at UIC now have changed our protocols. And while there's no prospective studies yet, and there's a phase 3 randomized clinical trials going on from Energy and Alliance Group, there are retrospect studies that supports pre-op SRS because you're treating less brain tissue, you're reducing the risk of radiation necrosis, and actually you might decrease the risk of leptomeningeal disease because the theory of the surgery with instrumentation that you might see the ventricles with cancer cells. Whole brain radiation, being established centers now, having the standard 10 days over 30 gray. And now there are studies that are looking into lower dose of whole brain radiation to understand if it will have the same effectiveness and with an effort to decrease side effects. A whole debate about SRS and whole brain radiation has been going on because we know that whole brain radiation duties that improves local control, so you stop having this pop-up of new brain mets scan by scan, but actually that does not translate to better overall survival, and you're getting a cost of cognitive difficulties of those patients. So that's why we like more SRS than whole brain radiation. It's the whole effort of understanding if we can treat 20 brain mets or more from the radiation oncology field. Brachytherapy is a whole debate in rad-onc world. There are now institutions that they have introduced brachytherapy. The idea that you are doing radiation of the resection cavity and potentially work better than SRS itself. But my understanding is that as many of you know, that has high cost, and we're not really sure if actually it will improve control and overall survival. So it remains to be seen, but there are supporters and others that they're skeptical still. The complication of radiation is also something that in neuro world we are struggling with, and we're trying to manage, and we have a collaboration with our radiation oncology folks. Symptomatic edema and radiation necrosis is one of the big ones. And again, with a whole brain radiation having cognitive difficulties. So radiation necrosis, pathophysiology is complicated, but has to do with angiogenesis and upregulation of VEGF. And now with all of these ADC, antibody drug conjugate drugs that are coming up, we know that potentially the concurrent use with SRS can increase the risk of radiation necrosis because the ADC payload synergizes with RT. We have retrospective studies now, and there's a lack of consensus what is considered concurrent, but the bigger studies from Memorial Sloan that supports the stopping the ADC drug 7 days prior to radiation, 3 weeks later. That's something that many times in our conversations through medical oncology and radiation oncology at UIC of coordinating care. When we have those radiation necrosis patients and they are symptomatic, options are steroids. Boswellia, actually, it's an extract like a herb. It's an Indian herb, for instance, that now there are a few small studies that supports the use for mild symptomatic patients with radiation necrosis. Hyperbaric oxygen is one of the other methods. I think the big guns that we have is advanced bevacizumab because it blocks the VEGF. And then also, as we said, the later interstitial chemotherapy. So this is a patient pre-Bev and post-Bev that had a radiation necrosis with great improvement of the edema and symptoms. When we're talking about whole brain radiation and cognitive effects, the efforts have been divided to use memantine from an RTOG study that now is standard of care that we're using for 6 months. Study was done for 6 months, but many times continue the memantine past the 6 months when the patients do have cognitive difficulties. Hypocampal spurring has been established from Dr. Gandhi. A study in 2014 was published that spurs the hippocampus and you have smaller decline recall. And at ASCO this year has been discussed that protocol of memory memory avoidance, hypocampus whole brain that also will avoid radiate other areas that are important for our memory as corpus callosum, amygdala, hypothalamus. So we'll see if that will be the new starter protocol in the future. So let's just talk a little bit about systemic treatment, and we're gonna divide between breast cancer, lung cancer, and melanoma. I'm not gonna talk so much about other primary malignancies. We'll be here until 9, but those are the larger innovations in our field, establishing systemic treatment for brain mets patients that many years before was just radiation and surgery and nothing else. What we're gonna talk about all of those different targeted treatments, we have to remember that it is heterogeneous disease, so many times the primary malignancy or other systemic meds might not have the same molecular background with the brain meds. So whenever we have a tissue from surgery of the brain meds, it's important to run the next generation sequencing to understand what's the molecular background of the brain meds itself. We have this theory of the HER2 flea on brain mets from breast cancer, that you can have HER2 negative disease in a primary breast cancer, but HER2 positive on brain mets. Sometimes the other way around can happen. I have seen that happening, but the most common is gaining that HER2 positive. So that's why it's important to run those markers to the brain tissue itself if you have tissue. For breast cancer, HER2 positive disease, traditionally we're using the landscape study lapatinib, and the NOLA study came with neratinib being the irreversible pan-HER inhibitor that improved survival of those patients. And I think most recently tucatinib, now not so much recent anymore, with a HER2 CLIVE that utilized tucatinib with capecitabine. That's so really enthusiastic results overall for those patients, including the brain mets. So that's a study of, that's a scheme of HER2 CLIVE that randomized patients with tucatinib, trastuzumab, capecitabine versus placebo, trastuzumab, and capecitabine. And the beauty of this study was that included active brain met patients and treated brain mets, and traditionally in the older clinical trials, these patients were excluded. And this is the overall survival and CNS progression-free survival, where you see that tucatinib grew double the PFS from 4.2 to 9.9. So very, very enthusiastic results. There were 75 patients of active brain mets that the double survival also got double, and then untreated radiation-naive patients that there were 66. With such enthusiastic intracranial objective response rate of 47 versus 17%. And then when we're thinking about that's all, trastuzumab deruxtecan came aboard the other ADC, using deruxtecan as a topoisomerase 1 inhibitor. And this is a meta-analysis of DESTINY-Breast1, 2, and 3 that you see on your left hand, the TDXT waterfall plot with response rate, and on the right side, the comparators that there were other HER2 targeted treatments, including lapatinib, TDM1. It was a heterogeneous group that you see the difference on the response of those patients. And on the bottom, exploratory progression-free survival graph, you can see on your right hand how enthusiastic results you see on the untreated active brain mets. So maybe TDXT also has a bigger role to those patients that have not been treated. You can see that probably drives even more response. And now we know with the new ASCO discussions of using TDXT earlier in the treatment of those patients, balancing out obviously the side effects of TDXT, that we might see a role of TDXT preventing patients from developing brain mets. So it's remained to be seen. We also know from the DEBRA study that HER2 low positive patients, they can also have intracranial objective response rate of 50% for those that they were asymptomatic and treated, and 33% for patients that they were progressing after radiation local therapy. That's a nice table I have been curated for that summarize a little bit the HER2 targeted treatments, and it was my chit chat for a long time. And you can see TDX didn't cut it for the more enthusiastic results. Now at ASCO this year was also announced the ACCREDITED study, which is the ADC patritumab deruxtecan that targets HER3 disease that's high on breast and non-small cell lung carcinoma. And they had 3 cohorts, the breast cancer with brain mets, lung cancer with brain mets, the lung carcinoma, and then the LMP from solid tumors. And those were the results that on breast, it was so 23.8% intracranial objective response rate, 30% in the lung cancer. But on the other hand, we had the Herthena Lung 02 study that it didn't show improvement on the overall survival. So we have to see this objective response rates will translate to survival benefit or not. They did, though, on subgroup analysis, resulted that it might have moreover the triple-negative breast cancer, that they are harder to treat those patients and not so many good options of the HER2 positive disease. And there was no association between HER3 overexpression and intracranial objective response rate. Then there was a study from Asia, the RAIN trial using trastuzumab deruxtecan, and that was the study design, and they announced at ASCO the cohort A HER2 positive disease, and they had cohort B HER2 low, but they did announce the R1 and R3 on ASCO, and you can see on R3 that was combined with bevacizumab, and those were the intracranial objective response rate. And the waterfall plot. So it was 84.4 for R1 and 72.7 for R3. So pretty promising, but we'll have to see bigger studies of, again, what will be the conclusion and the role of this agent. Total potamab deruxtecan also was a phase 2 study announced at ASCO that included brain mets and LMD. Results are not yet, but they're enrolling, and we'll have to see what will happen with this study. So that's the HER2 positive or HER2 negative. Unfortunately, lags behind, except of the obviously the HER2 low with the TDXD, as we mentioned with the DERA study, but not so much enthusiastic results with the CDK4 inhibitors with those patients, with abemaciclib having a little bit more CNS penetration than palbociclib, but though having 5.2% objective response rate. Capecitabine is another traditional chemotherapy drug that we're using, so we'll have more room to work on those HER2 negative patients. ASCO this year, this group, again, an Asia study using utenolone in combination with etoposide and Avastin. Utenolone being a novel microtubule inhibitor, and also the results so impressive objective response rate, but we'll have also to see bigger studies to understand those outcomes. Through extent study, triple negative disease, sacituzumab has been established, and now the ACCENT-04 study, combining sacituzumab with pembro, we have to see intracranially what that will, we'll have the results from. And then, as we mentioned, the ACCEDO3 study with a HER3 targeted treatment. But many times those patients also been treated with traditional chemo, with capecitabine or bevacizumab with targeted treatments. The ABC study also coming from the other side of the planet with Asia was a phase 2 study using anteprilimab PD-L1 inhibitor with Avastin combined with cisplatin carboplatin based chemo. So now we'll talk a little bit about lung cancer with non-small cell lung carcinoma, and those are all of the different mutations that we now have targeted treatments, and EGFR is the most, I think, studied and more enthusiastic results with osimertinib being the third generation TKI that has been proven to work for brain mets intracranially and also has a good CSF concentration, especially at a high dose of 160 milligrams daily. Osimertinib has been established with a FLORO study, the FLORO one showing improvement in the intracranial objective response rate over 91%, and then FLORA 2 study supporting the use of osimertinib combined with platinum-based chemotherapy that, as you can see, as well with patients with CNS metastasis at baseline had a hazard ratio of 0.47. But with ADORA trial, as Dr. Weinberg mentioned in his previous talk, with the early stage non-small cell lung carcinoma, we now have results of the risk of CNS disease of having 82% risk reduction on CNS recurrence or death with osimertinib. So we now think that also can have this preventative role for brain mets. Mariposa study was discussed at ASCO this year with amivantamab and lazertinib, amivantamab being the EGFR MET bispecific antibody, and lazertinib be the third generation EGFR TKI comparing with osimertinib. And that was the result of progression-free survival by baseline and brain mets. And you can see on your left hand that the brain mets patients also were together with and without history of brain mets on your right hand that follows that improvement on the PFS. Azacitidine is an interesting drug that was also discussed at ASCO this year, where it's similar with the osimertinib. It's a structural similarity, but they have used deuteration technology that reduces the toxic metabolites. And there was a phase 2 study in China with the idea that you might avoid the side effects of osimertinib with the rash and diarrhea. And those were the results of CNS response. You can see the osimertinib study on your left, and then at ASCO got announced as a azacitidine study on your right hand. So you can see similar objective response rate intracranially, and they have been discussed that actually azacitidine might have a role more in the exon 21 L858R mutation that we know that those patients are having lower efficacy on osimertinib. They had 13 patients that all of the 13 patients had intracranial response. So that might be even a subgroup that will even more be getting benefit from this agent. Interestingly enough, though, despite that we had lower risk of diarrhea and RAS, those patients, they actually had more myelosuppression. So that's something that we'll have to understand more with future studies of why is this difference on the myelosuppression percentages. ALK inhibitors, the main ones that have been established in the studies are alectinib with the ALEX study. That was a phase 3 study having 81% intracranial objective response rate. We're using 600 milligrams twice a day, and if you have progression, you can push to 900 milligrams twice a day for more intracranial response. And lorlatinib has been designed to overcome resistance with the CROWN trial, was a phase 3 study, also showing enthusiastic objective response, a rate of 82%. And red fusion patients, selpercatinib with the libretto study 001, and now with 431 study that compare with platinum-based chemo and pembro had shown also increase on the objective response rate intracranially. We have to see the second red fusion agent, pralsetinib, if we follow the same results and understand which agents to use with the accelerated lung study still pending results. Entrectinib is an established ROS1 translocation agent with a MET exon 14 splicing mutation with capmatinib. with small percentage of patients, but still having being a positive study. And unfortunately, with the KRAS G12C patients, adagrasib with the Crystal-1 has been now being, or have been using this agent, but hasn't been so much intracranial objective response rate. If you can think the higher percentages for those EGFR and ALK mutant patients with just median progression-free survival of 5.4 months. So we still have work to do with those patients. And we have to remember the immunotherapy part for brain mets. It was the old school, more driven data from the primary brain tumors that we still have difficulty establishing immunotherapy for those folks. A bit more cold tumors, but it's different for brain mets itself. And this is a summary of analysis, a full analysis of Keynote 021, 189, and 407 that you can see patients with brain mets with pembro and chemo compared to chemo itself, that you had less events of CNS with improvement of the overall survival. So that's something we have to remember to utilize for brain mets patients. Lastly, for melanoma patients, big two categories are the BRAF mutant patients with V600E mutation and the BRAF non-specific treatments with immunotherapy. With BRAF and MEK inhibitors using the BRAFenib and trametinib or vemurafenib and cobimetinib, and with the checkmate studies establishing obviously P-NIVO. So that's well-published studies been established, but the big discussion is which, especially for BRAF mutant patients, which agents to use first, BRAF inhibitors versus checkpoint inhibitors. And the idea is that the immunotherapy, especially for brain mets patients that they have vasogenic edema, you might have longer when you have response of those patients more like long-term versus the BRAF inhibitors, they can work faster, but I think the data now supports more of durable responses for patients utilizing immunotherapy. The checkmate 204 and ABC trial that were done more in the asymptomatic is a little bit easier to treat brain mets, having higher objective response rate, as you can see. And at ASCO this year, Dr. Atkins discussed about the phase 3 DREAM sequence trial, comparing EP and NIVO, followed by NIVO maintenance versus the BRAF trametinib. And now there is supporting data using immunotherapy upfront for the BRAF mutant patients. And those were the CNS metastasis-free survival graphs supporting that. But I think still the difficulties we're facing are with symptomatic brain mets patients, and they have a lot of edema, and we know that steroids can decrease the efficacy of both of the BRAF targeted treatments, but much higher to the immunotherapy patients. So we do see lower intracranial response with those patients with all of those different treatment regimens, and that's something we have to work better and find steroid-sparing methods, and now utilizing bevacizumab is one of them that we're trying to get established. We're going to close a little bit with leptomeningeal disease itself. We know that has dismissal prognosis, and radiation also has been on the area of radiation systemic and intrathecal agents in some institutions. With the latest innovation radiation, having established the craniospinal radiation with the phase 2 study that compare proton CSI comparing to photon, but with focal fields, not photon craniospinal, that did establish the role of proton CSI with improvement of the survival. And there's an energy phase 3 study going on, and we're waiting the results. The difficulties we have is that not all of the institutions have photon, proton radiation, and that's where we're struggling with not all of the patients having access. And there's a study going on of understanding photon CSI, avoiding the bone marrow, if we'll have less toxicity and similar results with the proton CSI. For systemic treatment with a HER2 targeted, as we talk about, cadmium and DDXD is also efficacious to the LMD patients too. This is the osimertinib study with the Bloom trial, the Aura trial using osimertinib, and there's a debate about 80 milligrams versus 160 milligrams with not good prospective comparison. And back to the Marvel's study, also on the nivolumab and lazertinib also survival benefit for LMD cohort 2. Not all of the institutions are supporting of the intrathecal treatments, but at UIC we do advocate for intrathecal treatments when we have good functionality of those patients, and many have been studied, including IT trastuzumab, with a French study published in 2022. Topotecan's traditional chemo for all comers, solid tumors has been established for a study of 2008. And now we're trying to understand the ID pembrolizumab, especially for melanoma patients and LMD. There are a lot of ongoing clinical trials. The larger ones are on the breast HER2 positive group, utilizing IT now trastuzumab with pertuzumab. And there's an ongoing phase 2 study, and also a radioisotope radiation study with the Radium 186. Doing a CSI for LMD patients. So that I'll close and I'll take any questions. Thank you for attending my talk.
Okay. Thank you very much. And right now we're getting ready to go on a break. Let me see what time it is. 3:11. We're about 20 minutes ahead. So how about we come back around 4? You guys good with that? 4 p.m. after the break, and then we'll start the presentation a little earlier and end a little early. All right. Thank you guys.
Okay, be back at 4. Maybe next week.
Do I end it? This is
Muted?
yeah,
Exactly. Say it again? Okay, perfect, no rush. Now I don't know if this was mine or that was mine.
Take the unopened one.
I think they both opened.
Oh.
I just can't tell which is mine. I'm gonna go grab a new one, but I'm gonna put them both here.
So as everyone settles in, I'm going to start the next two sessions here, and we're going to start with Dr. Shikha Jain. I first met Shikha Jain 5 years ago, and no one actually calls her Shikha or Dr. Jain. We just call her the Shikha Jain because there's one and only Shikha Jain in the world. In addition to being an outstanding clinician, investigator, she wears many hats around the Cancer Center, and I'm not going to spend the next 30 minutes just describing those things. But needless to say, she is one of the most influential cancer researchers, period. Her work on giving voice to physicians in the workplace that don't necessarily always get voice is, I think, one of her strongest, biggest contributions to medicine in general. This is not just in oncology. She's also the founder of WIM, Women in Medicine, which I will tell you, when it used to be called Twitter, every time they had their meeting, they would have 50 million impressions from that meeting just from an afternoon. So this is why we call her the Shikha Jain. And I'm going to share just one anecdote before I bring her up here. I once thought she needed help kind of getting to know some breast cancer people because she was attending a breast cancer meeting. And when I texted my friends that she was coming, this is literally their response. Shikha Jain, Shikha Jain, Shikha Jain. You thought Bono was being introduced to them. Anyway, Dr. Jain, please come on up. This is going to be a very important lecture. There's lots going on in pancreas cancer, and we're going to get some updates on this.
Thank you for that lovely, kind introduction. And just for the record, it was 78 million, not 50 million. So anyway, so I am Dr. Shikha Jain. I'm a GI oncologist at the University of Illinois Cancer Center, and I'm going to be talking to you about pancreatic cancer. I had a mentor back when I was a fellow who said there were two cancers that gave oncologists a bad name: melanoma and pancreatic cancer. Now, melanoma got a second wind with all of the amazing immunotherapy data that came out. Pancreas cancer still, unfortunately, is still struggling to get that win. So there was some interesting data this year at ASCO. I'm going to talk a little bit about it. I'm going to give a little bit of an overview about pancreatic cancer as well. There isn't as much exciting stuff happening in the pancreatic space, but I am optimistic that we will start to see some of the seeds that have been planted in the last couple of years start to come to fruition. Let's see if this works. Do I have to point it somewhere specific? There we go. I have some disclosures. I've been on some speakers bureaus and objectives. So today we'll be talking about some update on the current standard of care for pancreatic cancer. We'll be reviewing some pivotal clinical trials and some newer data, exploring the evolving role of biomarkers, and highlighting some innovation in detection and precision therapy. So I'm going to give some general statistics. Pancreatic cancer, there's over 65,000 new cases in the US per year. 5-year overall survival is around 13% or less. Most patients present with metastatic disease because there are no opportunities for screening, really, in pancreatic cancer. And genomic profiling and trial access are really critical to progress. I have a lot of friends who practice in the community, and the one thing I say, if I ever talk to them about pancreatic cancer, get next generation sequencing every single time. And now I'm also telling them to get HER2 testing because we are seeing more and more cancers show up with genomic profiles that I personally did not even know existed for them back when I was a trainee because we weren't testing as much. The more we test, the more information we get. So when we come to talking about diagnosis and staging, again, most of this is pretty basic, run of the mill. high-quality pancreatic protocol CTs, MRIs, EUS or CT-guided biopsies, CA19-9. This is a really important key point here is the multidisciplinary tumor board evaluation and multidisciplinary approach. One thing that gives me a lot of joy is whether you're in the community, whether you're in an academic center, rural, urban, wherever you are, most people are having multidisciplinary discussions. And I've also seen more and more tumor boards happening in community settings, which is great, especially for these very complex patients. At University of Illinois, was not here all day, but I'm sure someone mentioned our precision oncology tumor board that was launched at our institution where external people can actually present cases. And we've actually seen real benefit from that. So the sad thing in pancreatic cancer is there hasn't been a lot of exciting stuff when it comes to first-line therapy in the metastatic or in the locally advanced space. FOLFIRINOX and Abraxane are kind of the standards. They've always been the standards. FOLFIRINOX for people who are robust, who have very good performance status, and gemcitabine and Abraxane for metastatic disease for those patients who don't have as robust of a performance status. The choice is based on performance status, comorbidity, and age. I joke because some of our patients come in and they're like 85, but they look 55. And so sometimes I tell my patients, you've got the body of a 85-year-old, but you have the physicality of a 55-year-old. How do I decide which chemo to give you? And so it's really about personalizing the care to patients, thinking about their performance status, their other comorbidities, and not just looking at age as a number. And again, NCCN recommends upfront molecular profiling. I recommend it as well. So the initial systemic therapy with pancreatic cancer, again, most patients present with advanced disease. If they present with early stage disease, sometimes we talk about giving systemic therapy to downstage them or in the hopes of making them surgical candidates if they're not at the time of presentation. I talked about FOLFIRINOX and gemcitabine, and usually we try to give at least 3 months of therapy in the neoadjuvant setting before we re-image. Most patients get about 6 months of neoadjuvant therapy before being considered for surgery. We usually image every 2 to 3 months, and again, I emphasize this. I'll discuss this with some of the trials, but there's questions as to whether chemo upfront or surgery upfront is beneficial. Many of these patients who are locally advanced, who present with disease that may or may not be resectable, we really recommend upfront chemotherapy, and I'll explain why. My surgical colleagues get really frustrated sometimes because we talk about consolidation therapy with chemo and radiation. One of my favorite surgeons sat me down and said, here's the deal. We do radiation when we absolutely need it, but as surgeons, we hate it because it makes the tumor bed very sticky. And so if you can get away with giving systemic therapy and not radiation, many surgeons prefer it because it makes for better surgical outcomes and a better chance of less mortality, less morbidity, and a higher ability to remove the entire tumor. However, there are some cases where patients do need consolidation therapy in the neoadjuvant setting. There are some cases where patients have locally advanced disease and they are not a candidate for surgery that we would actually give chemo followed by chemo-RT for local control, even if they aren't surgical candidates. And again, you can sometimes try and convert a locally advanced non-surgical candidate to a surgical candidate, but that is pretty difficult to do. I think I've done it 3 or 4 times in my career. So surgery, this is another really key point. There's a lot of, my dad's a surgeon, so I always joke with him that I talk to surgeons now more than I did as a kid. But I think that it's really important when you have a surgeon who is doing the procedure, that they've done a lot of high volume cases, they've done a lot of Whipples, not only because you want them to be very surgically skilled, but data changes, we need to know how many lymph nodes they've removed, and having a multidisciplinary approach with a surgeon who understands the oncology portion of it is very important. So ideally you have a surgeon who's trained surgical oncologist, have had biliary surgeons, and again, multidisciplinary care. All right, so this is our favorite NCCN. I always bring this up because for those of you who've ever shadowed me in clinic or heard me talk, I'm very big on informed decision-making with patients. So anytime I sit down with the patient, we'll sit in the room, I'll talk at them, and it really is talking at them because your first, second, and third oncology visit, usually most patients forget 80% of the conversation because it can be overwhelming. So what I try to do and what seems to work is I pull up NCCN guidelines and I walk patients through and then I send them home with a handout that explains what exactly their treatment plan will be. So if you look here for NCCN for resectable disease, patients who have surgery is recommended in the absence of high-risk features. The high-risk features include equivocal or indeterminate imaging findings, markedly elevated CA19-9, large primary tumor, large regional lymph nodes, excessive weight loss, or extreme pain. So all of those put patients in a category where we would usually recommend neoadjuvant therapy first. And to be perfectly frank, 99% of my patients, I recommend neoadjuvant therapy to. There's a couple of reasons for that. Number one, can help with local control and hopefully make the surgery less complicated. But the real reason is pancreatic cancer can grow quickly. And after surgery, you usually have to wait at least 4 to 6 weeks before you start systemic therapy. If you have a patient who has locally advanced disease with micrometastatic disease that you cannot see, and you send them for surgery first, there is a high chance that the cancers that are the micrometastatic cells will start to grow during that time period. And you've now done a major surgery and have made it so the patient can no longer be cured. So most of my patients, I usually lean towards the neoadjuvant therapy. The 2 times, I can literally count it on my hand, the 2 times I have not done neoadjuvant, one was this woman came in and her tumor was so small that basically she had a biopsy that showed she had a pancreatic adenocarcinoma and no one could see it on imaging. It was so tiny that we had the pathology, but we didn't have the actual imaging to show where it was. So in her case, we did surgery up front. She ended up getting adjuvant therapy and she did fine. And the second case was somebody, again, who had a very, very small tumor where the chance of micrometastatic disease was pretty minimal. So I usually lean towards neoadjuvant therapy. In patients who did not get systemic therapy preoperatively, after they have surgery, we typically recommend adjuvant therapy for all of them. This is just more on neoadjuvant therapy. We sometimes recommend a staging laparoscopy prior to surgery as well. If the patient does well with neoadjuvant therapy, if the disease stays stable or gets smaller, then you can send them to surgery. So I'm going to go back to 2011, which we're going to start talking about some trials that have impacted how we continue to currently treat our patients. So this was the Prodigy 4 Cohort 11 trial back in 2011. This data was published and they were looking at FOLFIRINOX versus gemcitabine in the metastatic pancreatic cancer patient. I bring this up because again, it's been 14 years since then and we're still doing a lot of the same things. So this trial basically looked at FOLFIRINOX versus gemcitabine for people with metastatic pancreatic CA with good performance status. And what they found was that FOLFIRINOX had improved progression-free survival, overall response rate. However, significantly more quality of life issues and side effects because it's a tough regimen to get through. There was no significant overall survival difference by gender, though the trend favored females. And really, this is one of the trials that led to FOLFIRINOX becoming standard of care for many of our patients. Now, looking at Prodigy as it's evolved through the years and newer trials that have come out, there was another trial that looked at FOLFIRINOX versus adjuvant gemcitabine in pancreatic cancer patients. And what this trial found was that adjuvant therapy with modified FOLFIRINOX led to significantly longer overall survival compared to gemcitabine single agent. Again, I'm just trying to show the history of where we've come, where FOLFIRINOX still seems to be number 1, and gemcitabine or gemabraxane are the next option. So these are 2 of the more well-known, the Prodigy 4 and the Prodigy 24 trials. And because of those 2, Prodigy 4, FOLFIRINOX became first line in all patients who are metastatic with good performance status. And with the overall survival benefit of 54 months versus 35 months, FOLFIRINOX was also the standard of care for adjuvant therapy. So most of my patients, that's what they get unless they have other major challenges. Now this trial, so this is the Prodigy 24, the final 4-year results from this trial, again, looking at adjuvant therapy in the modified FOLFIRINOX versus gemcitabine group. And it also improved disease-free survival, 21.6 months versus 12.8 months. So again, that's what set the standard for these patients. Now, let's look at FOLFIRINOX versus Gem/Abraxane. So this again, this was a study looked at improved survival of approximately 2 months is what they found compared with Gem/Abraxane. So a lot of people question, oh, those PROTEGE trials, they didn't include Abraxane, so maybe Gem/Abraxane is better. But this trial has proved that Gem/Abraxane did have a better quality of life and less complications. However, FOLFIRINOX was overall better for overall survival. So again, you'll hear me talk about those two regimens a lot because in the pancreatic space, those are really what we give. However, now I'm going to push my way into the breast cancer space. Back in the day, we didn't really talk about BRCA when it came to pancreatic cancer, but what we've actually found is that there are benefits for tailoring care to patients who have BRCA1 or BRCA2 or PALB2 mutation. And so in those particular patients, we still recommend FOLFIRINOX. That is the standard that we recommend in the upfront setting. However, gemcitabine plus cisplatin can also be given to this patient population. And if the patients progress, and this is where we bump into the breast cancer space, if the patients have had previous platinum-based chemotherapy, they can get olaparib, but that's only for patients who have BRCA1 and BRCA2 mutations. So is there exciting stuff happening in pancreatic? Yes. Why are we able to do it? Because now we're actually checking mutations, next generation sequencing, and doing more targeted and personalized precision oncology. So let's talk about the POLO trial. This is a phase 3 study of active maintenance olaparib versus placebo for germline BRCA mutated metastatic pancreatic cancer patients. Oh my goodness, that is very small. I'm really sorry. It's probably very difficult for you to read. So I will tell you the high points. So basically it started off over 3,000 patients were assessed for eligibility. 247 had a germline BRCA mutation. And it ended up 167 patients ended up consenting for this trial. 13 were excluded because they didn't meet eligibility criteria. So at the end of the day, 154 patients underwent randomization. And they were assigned to either receive olaparib or they were assigned to receive placebo. And at the time of cutoff, 30 patients were still receiving olaparib and 8 were still receiving placebo. So this was a POLO trial results, and I don't know if this pointer works. Is there a pointer? There's not. I'm just gonna walk. All right. So if you look at olaparib, it had 92 patients, placebo had 62. If you look at the overall survival, you can see the Kaplan-Meier curve is pretty nicely separated with a hazard ratio of 0.83. The median overall survival for those in the olaparib maintenance was 19 months, and placebo was 19.2. So while definitely trended towards maybe a benefit, they didn't actually see an overall survival benefit. However, all of the patients who were in the trial, they all had non-progression after 16 weeks of platinum-based chemotherapy. That's how they were eligible for this trial. And the median progression-free survival is what made this a bit exciting for pancreatic cancer patients, where it was a 7.4-month progression-free survival for olaparib group and 3.8 months for placebo. There wasn't a significant overall survival difference, but there was also a response rate and a duration of response difference of 23% versus 12% for response rate and 24.9 versus 3.7 months for duration of response. So again, this reinforces the need we need to be doing germline BRCA testing in these patients, and olaparib may be an option for maintenance in these patients after they've been stable with previous platinum-based chemotherapy for over 16 weeks. Again, no overall survival benefit, but when it comes to pancreatic cancer, we take our wins where we can. A progression-free benefit and the response rate and duration of response benefit is definitely nothing to sneeze at. So the Alliance trial, this is something I mentioned briefly to you earlier, talking about neoadjuvant versus adjuvant chemo for resectable pancreatic cancer. These are discussions, again, that are so important to have with your surgery colleagues because we talk about it all the time. Does this patient need chemo first or do they need surgery first? So the Alliance trial, it's a phase 3 trial of perioperative versus adjuvant chemo for resectable pancreatic cancer patients. And basically, arm 1 is perioperative FOLFIRINOX. Okay, it's 8 cycles pre and 4 cycles post-surgery. Arm 2 is surgery followed by adjuvant chemo with FOLFIRINOX, and you get all 12 cycles post-operatively. So the outcomes that are being evaluated in this trial, predominant primary outcome is overall survival, then also looking at disease-free survival, time to local regional recurrence, time to distant mets, and compare resectability and pathological response. The data is not out for this study yet. I think it's going to be really interesting. And I will tell you the heated discussions that I have with my surgery colleagues about preoperative chemo versus postoperative chemo. I think this will hopefully give us a little bit more information on if there's a benefit one way or another for perioperative neoadjuvant or adjuvant systemic therapy. So the PANOVA trial. So pancreatic cancer never gets on the front page of ASCO Daily, like ever at ASCO. It never happens. I've never seen it since I've been going to ASCO. I opened my ASCO Daily at ASCO and I saw pancreatic cancer in a little section at the bottom. And I was like, what is this? This never happens. And it was the PANOVA trial. And it's really interesting, but I'm going to start with this caveat that the technology utilized in this trial, I do not know as intimately as I would like. It has been used quite a bit in the gyn-onc space, but it has not really made its way over to us until these types of trials. So my next month is going to be spent learning more about it because it is really fascinating the way this technology works. So basically it's talking about targeting pancreatic cancer with tumor treating fields plus chemo. So this is a phase 2 study evaluating the use of TT fields in combination with Gem-Abraxane. And they looked at patients with locally advanced pancreatic cancer. So what are TT fields? That's what I wanted to know. They're non-invasive treatment modality using alternating electrical fields to disrupt cancer cell division, which sounds very woo-woo to me when I was reading it initially, but it was on the front page of ASCO Daily, so it has to be real, right? The objective of this study was to assess safety, feasibility, and preliminary efficacy of combining TT fields with chemotherapy. So this was actually presented back in 2016 in the PANOVA-2 trial, which is where it was first presented. And that was the foundation of the phase 3 study that was presented this year. So the phase 2 pilot study was presented at ASCO GI in January 2016, and it actually showed a progression-free survival and overall survival benefit for patients treated with these TT fields with gemcitabine, and it was more than double those patients who just got gemcitabine alone. So when they presented it in 2016, they showed this overall survival benefit. The overall survival was 14.9 months for patients who got this TT fields with gemcitabine versus patients who got gemcitabine alone. There was also a significant difference in the progression-free survival of 8.3 months versus 3.7 months. The 1-year survival rate was 55% versus 22%. Partial response rate, 30% versus 7%. So in the pancreatic cancer world, these are pretty great numbers. And that's what led to the next trial that was presented at this year's ASCO. So this is PANOVA-3. So until I saw this picture, I'd never seen what TT fields looked like. So it looks like what this guy's wearing here. So what is tumor treating fields? They're a novel, non-invasive method for treating cancer. They utilize this low intensity alternating electrical fields that interfere with the process of mitosis. And because, as we know, how do cancer cells grow? They proliferate without any regulation. So the thought is that these electrical fields kind of disrupt that replication. And the thought is that they can inhibit or slow down tumor growth. Again, it all sounds very woo-woo. It sounds very science fiction, kind of how we used to think about CAR T therapy. Like I have a slide for my fellowship where I put up a picture of a dinosaur combined with a turkey. And it basically said genetic engineering. It's not just for science fiction anymore. That's how I used to think of CAR T therapy when I was learning about it. And that's how, when you read about this or hear about this, it sounds like that. It sounds like science fiction. But we actually have data that shows it seems to work. So how do our TT fields deliver to the pancreas? So the system, it's a portable medical device, delivers treatment via insulated transducer arrays, which attach around the abdomen, as you can see on this patient, and it delivers these fields directly to the pancreas. It's been tested in a clinical trial for this locally advanced pancreatic cancer. It's portable, they say it's simple to operate. They have these lovely pictures of people who are walking around. It sounds, they probably have the thing underneath their shirt. So it seems like it's easy to wear. So they have multiple distinct mechanisms of action. These are the different ways it works. There's disruption of mitosis. There's the interference of the cell movement and migration, downregulation of DNA damage response, and a downstream enhancement of anti-tumor immunity. So these are the different mechanisms for how these fields seek to work. And this is some of the data that was presented. So if you look here, the median survival benefit for TTF fields plus gem and Abraxane was 16.2 median survival and 14.2 months for gem Abraxane alone. My question would be, what is the data with FOLFIRINOX? Because as we talked about, FOLFIRINOX is superior to gem Abraxane. It's really interesting when you're looking at the progression-free survival. Again, pretty impressive numbers for pancreatic cancer, 10.6 versus 9.3 months for progression-free survival. Looking at pain-free survival, because we also care about quality of life. So looking at the pain-free survival numbers, 15.2 months in the TTF group versus 9.1 months in the gem-Abraxane alone group. And looking at distant progression-free survival, again, nice numbers of 13.9 months versus 11.5 months. So what are the key points from this particular trial? Overall survival benefit of about 2 months. Median pain-free survival of about 4 months. 1-year survival rate of about 8% difference. Improved quality of life and pretty safe. Before I get to the next slide, one thing I want to talk about, though, I'm going to go back to the picture of the man wearing it. So the challenge with this, however, I think it's really exciting and it could be transformative, but how accessible is it going to be to patients, especially our patient populations who have challenges accessing these types of things? How expensive is it going to be? Is it going to be available outside of academic centers? So one thing I always bring up at ASCO, anytime I talk to anyone, it's awesome, the new technologies, the new innovation, but we need to make sure we're making it accessible to our patients. Otherwise, there's no point. We can keep doing great stuff, but if it's not getting into the hands of the patients, then we can keep patting ourselves on the back. Would like to actually see it improve patients outside of clinical trials as well. But it is a very cool technology. I'll be curious to see what ends up coming of it. I was on a panel with a bunch of GI oncologists from all over the country, and the gentleman from Sloan Kettering was very excited about this because he thinks it might transform the way we treat these patients. And I'm cautiously optimistic as an oncologist, but again, I hope we can make it accessible to all of our patients. So I'm going to talk a little bit about KRAS, because KRAS is like the hot ticket these days and everybody loves KRAS. And we see KRAS in many of our patients. It's the most commonly mutated oncogene in PDAC patients. The most frequent variants are G12D, G12V, G12RC are a little bit less common. We know that KRAS activation drives tumor proliferation. In the past, it was considered undruggable, meaning we couldn't target it, but we're starting to see pan-RAS and targeted RAS agents that are seeing some promise in other tumors, so we are optimistic about pancreas. As I said, G12C is only about 1 to 2% of PDAC. Agents like sotorasib have been found to be useful in these patients in many other cancers, so the hope is we'll start to see more and more RAS agents, pan-RAS or targeted RAS agents be beneficial in the pancreatic cancer space. I'm going to talk briefly about ctDNA. So I use ctDNA pretty globally with all of my metastatic patients and with my curative intent patients. The challenge is we need more data and how we can actually use these in an informed way. In my patients who are cured, I say cured with air quotes, I usually get a ctDNA postoperatively and monitor it very carefully with the caveat to my patients that I'm utilizing this to really assess your risk of recurrence and to better monitor your overall malignancy and how we can decide if we need to start monitoring you more closely or restart therapy. ctDNA can be predictive of early relapse. I think it's really going to be interesting as we get more and more data around MRD, how we can best use it to best make sure we're not over-treating our patients, but also make sure that we are monitoring our patients for recurrence. So Circulate is a prospective study looking at ctDNA guided treatment in resected PDAC. The goal is to use tumor-informed ctDNA assays to monitor MRD. And early findings again suggest that ctDNA positivity post-surgery will predict a poor disease-free survival. And ctDNA clearance should hopefully correlate with a good treatment response and long-term survival. So the hope is that it will help us in the adjuvant setting with these patients. Can't talk about cancer these days without talking about AI. I'm not going to go into a lot of detail about AI, but I will tell you one thing, AI is not going to replace doctors, no matter what you hear on TV. But there are ways to utilize AI to actually enhance the way we're taking care of our patients. I will tell you a funny caveat of one way I've used AI, and it has helped me globally. Anytime I get a denial letter and I have to write a letter back, I do a really thorough job of writing a very good letter, and it all comes from AI. So you can use ChatGPT to do that, just in case you were wondering. And it always works because they write everything that they want to hear in it. So, but other ways we can use AI models, we can use it to enhance EUS, CT interpretations. There's algorithms that are trying to identify how to best stratify risk using the EMR data. And there's also some promising research looking at high-risk screening settings and how can we utilize AI. I think that AI is going to, regardless of whether we want it to or not, AI is going to become a big part of how we treat oncology patients with cancer. The question is, how are we going to best use it to our benefit and to benefit our patients? I can't talk on a stage about cancer without emphasizing the fact that trial access and disparities are a huge problem. At UIC, the majority of our patients are not patients that you see on clinical trials. When you look at the demographics, our patient population is just not represented. And so that is a huge problem because oncology is a heterogeneous, cancer is a heterogeneous disease, and patients are not homogeneous. And so if we are not enrolling the patients that we are serving in our communities into these trials, we are doing not only a huge disservice to them, we are also really negatively impacting our data because we don't actually know if the patients we're treating are getting the best personalized care because they aren't included in the trials. So we need to make sure that we are emphasizing and focusing on getting those patients into trials, regardless of what is happening nationally, internationally, globally. We need to make sure that our patient populations are represented, and we're seeing more and more shift towards that. But I encourage you, if you are somebody who has a platform, who is able to advocate for that, continue to do that because it's incredibly important. And there's policy efforts in place that can help with that as well. So I'm going to end with just a little bit of the challenges that we face in the pancreatic cancer space. So there's a high prevalence of metastatic disease and a high tumor burden for most patients when they initially present. The other challenge that happens, many pancreatic patients, they have cachexia, they have muscle wasting, they are overall poor performance status, they've got body fat loss, metabolic dysregulation because their pancreas is impacted. And so there's a lot of challenges when it comes to treating pancreatic cancer patients. Again, that's why pancreatic cancer gives oncologists a bad name, because we have not been able to make the advances that has been seen in other spaces. But I'm all about positivity, so let's talk about opportunities for how we can improve on that. One, we need to be thinking really, really strategically about what are the ways that we can use these novel biomarkers, precision oncology, next generation sequencing to really target patients appropriately. How can we think about early detection in pancreatic cancer? We've got it in colon cancer, we've got it in breast cancer. We should be thinking, how can we start doing more in the early detection space with pancreatic cancer? Metastatic specific treatments, treatments for cachexia. So I actually was at an event this morning talking about the benefits of kefir or a kefir, depending on where you're from, and how that actually can help with nutrition. We need to be thinking about the whole patient, not just about the chemo and the surgery, but also how can we support them with their weight gain, making sure we get the nutritionist involved, making sure we get physical therapy involved. Because another really exciting study out of ASCO actually showed that exercise has a major impact on patient survival when it comes to cancer and on recurrence rates. So we need to be thinking not just about the drugs and the electronic fields and the surgery, but we need to be thinking about the nutrition and the overall health of the patient. Targeting immune, micro and microenvironments, so thinking about vaccines and vaccine studies that have been transformative in some of the other cancer spaces, novel combinations for immunotherapy, ICIs, biomarkers, chemotherapy, thinking about modulation of immunosuppressive cells. KRAS, like I said, KRAS is like the popular girl in high school right now. Everybody wants a KRAS trial. So thinking how can we incorporate KRAS into our pancreatic cancer trials, and really addressing the challenges that we face when it comes to disparities in cancer care as a whole, thinking about increasing funding, PDAC-specific treatments, and more trials for these particular patients. So take-home messages. Number one, refer patients for trials early. Biomarker-driven options are growing, and there are more and more trials in that space. Genetic and somatic testing is key. Keep up with evolving standards, and equity in care and trial access must improve. And with that, I'm hoping by the time I retire, pancreatic cancer no longer gives us a bad name. And that's it. Thank you.
While we're waiting on questions, I have a question about the treatment fields technology. It's approved already in glioblastoma. Now we have potentially another indication. In the studies, in the control group, are they wearing a device, not wearing a device? And if they're wearing a device, is the device scrambled in a way where the signals are not real signals? I worry about placebo effects with agents or with interventions like this.
So
I'm gonna say I don't know the answer to that. But what I will say is I'm worried about that as well, about the concept of placebo effect and whether there actually is a benefit, which is why, I mean, we saw it with PANOVA 2, right? That's how they first got the approval to do PANOVA 3. So in clinical trials, if we continue to see replicated data, I'm assuming that hopefully it's not a placebo effect. It has been shown to be beneficial in other diseases, so I'm, again, cautiously optimistic, but I don't know the exact data.
Are there any other questions on pancreas?
How often, so do you typically give the 6 months of chemo, like perioperative chemo upfront, or do you try and do it all around? And like how often do people actually complete their post-surgical chemo?
So great question. So the question, in case you couldn't hear it, with perioperative chemo, do I usually give all 6 months up front, or do I do a half and half? And how often do patients actually complete all of it? So what I typically do, my standard I tell patients, I say, you're definitely getting 3 months of chemo, so buckle up for 3 months of chemo. Sometimes we dose modify for side effects, and if their CA19-9 is going up during that time, I will usually scan earlier than 3 months to make sure that they are actually responding. At the 3-month mark, I'll do imaging. If the imaging shows a phenomenal response, I call my surgeon and I say, hey, what do you think? Do you want to take the patient to the OR now, or do you want to do another 3 months of chemo? So it's shared decision-making with the patient and with the surgeon. Most of the time, we do the entire 6 months up front. I have, what I will say, and when I do the entire 6 months up front, most of my patients make it through usually about 5 to 5.5 months. Sometimes what I do with patients is that they get to month like 4.5, 5, and they're like, Dr. Jane, I'm miserable. This sucks. Can you stop? And then we'll re-image. And then if it looks like they're safe for surgery, I'll tell them, yes, we can stop. We will do surgery, but we likely are going to do more chemo after. So I really try to do that 6 months overall to give them the best benefit. And I try to get as much of it in as I can preoperatively. But again, if I need to dose reduce, if I need to hold, if I need to delay. The other thing is if my patients are starting to develop severe neutropenia, or if their toxicities are too high, then it's shared decision making with the patient. And I tell them, these are the risks, these are the benefits. Let's talk about making sure quality of life is also a focus. But we try really hard to get it up front if we can.
All right, thank you.
Thank you.
And as Dr. Jane leaves the podium here, let's all wish her good luck next week when she's vying for an Emmy Award in New York City. Yeah, that's what I said.
Thank you.
Hold on, I got it. Okay.
So we're going to take a little bit of a different turn here. I'm going to talk about antibody drug conjugates, which are relatively speaking an old therapeutic class that's enjoyed quite a bit of renaissance right now. there's lots and lots of drugs and lots of indication. And I just wanted to be introspective about the space and the drugs and kind of how we think they work.
Bear with me.
Okay, no worries. I'm used to karaoke and I hold a mic like this. I'll spare you that.
I just need to make sure I get the proper slide shared. Here we go. I have it.
Thank you. So really today is about learning about how ADCs maybe were conceived and developed, and then how we integrate them into our practice and strategies right now. So quickly, I'll just kind of explore the market in general, then we'll talk about the MOA for these drugs. In Joseph Campbell's terms, the tortured path of the hero. So didn't start out great, but we're seeming to end up on a very high note. And then mostly updates focused on breast cancer and new indications in breast cancer, because I'm a breast cancer doctor. But I think it just gives you an idea of how we're generally thinking about these agents. So this is small purposefully, but this is just the list, the comprehensive list that's at this moment of drugs that are approved in various cancers, the initial approval for various agents. There's about 14, 15 agents up here now. And, you know, going across, you see which generation of agent they are, the name of the drug, the target. There's a handful of targets, really not a lot have been explored, at least in terms of those agents that are approved, but more to come. And then what's the antibody, the linker, and the payload? So that's the composite of the three things that need to get together. There's a term called DAR, or drug antibody ratio. So how much of the chemotherapy per molecule of antibody. And you can see the numbers vary anywhere from just a very low of 1.8 all the way up to 8. So it just really depends on the agent and the potency of the agent. A number of different initial indications, but when something works in a disease, we may start exploring it in others. And you'll see going back to the first of these drugs approved more than 15 years ago, but approvals as recently as just a few weeks ago. In particular, these two agents this year. So I will just say, I use this word too much, my wife says, but this is one of the frothiest area of drug development. By that, I mean, there's a lot of money going into this space. So there's, first of all, lots of drugs, and this is just to highlight, this is a recent poll from clinicaltrials.gov, 282 active enrolling trials right now with ADCs. This is just a market estimate of the market reaching $30 billion by 2028. That is a substantial size of the entire oncology market. And then just to give an example of some of the investments, you've got acquisitions running wild in this space with big companies swallowing up smaller companies. Some of my best friends have done very well in the last few years here, having been innovators, founders, or just simply working in some of these companies. So this just is drawing a lot of attention. So what's all this attention about? Well, before I jump to that, I want to say we as an institution have also contributed to some of these trials. This is just a list from the NCTN website on trials that we have currently open at our institution. They span children's oncology, but also adults with AML. Quite recently, and I'll talk about this a little bit, the ASCENT-04 study was published presented at ASCO as a positive top-line trial that's now going to set the new standard of care for first-line therapy of patients with metastatic breast cancer that's triple negative, in combination with chemotherapy with the drug sacituzumab govitecan, an ADC that we've had some experience with. We participated on this trial. We enroll patients to this study. I still have those patients in my panel, so we're very proud to have been part of this story. And then just to follow up on that, even though this is a molecule, sacituzumab govitecan, there's already new drugs that are building on that target with a similar payload, but with different sort of tweaks that might improve on the signal. This is a paper that was published primarily in the Chinese patient population that was presented at ASCO just a few weeks ago, but we do have the American version of this trial from Pfizer from Merck up and running at our institution. And there it is right there. So with that sort of background of what this space looks like, our involvement, the city of Chicago, what we're doing at our cancer center, let's kind of talk about the drugs just for a minute. Let's go backwards. Let's get started. That video went too fast, but I kind of want you to watch this. All right. So the dogma is you have an antibody, you have a linker, and then you have drug. The dogma is that this complex enters a cancer cell, the linker is then dissolved in some way, essentially cleaved, and then the drug from within the cancer cell is released and identifies whatever its target is. Some of these targets are DNA damaging agents, some are microtubule inhibiting agents, whatever it is. These are conventional chemotherapies that are oftentimes too toxic just to give in an IV, but when attached and safely delivered to a target cell, can get there in meaningful quantities and kill the cells from within. Some of these molecules then leak out of that environment and start killing their bystander cells around it. So you don't even have to get every cell within the tumor microenvironment. Just getting a handful of cells can see some effect. We call this the bystander effect. So these are some of the putative mechanisms that have been thrown out. This is a nice review from Tolcher et al. In 2023. Part of the reason for doing an antibody drug conjugate is to do something called increasing the therapeutic index. So going backwards in time, we learned that there's two concepts. There's the minimally effective dose here on the slide called the MED, and then the maximally tolerated dose. So you want to give something that's minimally effective, but not get so bad that it's harmful to the patient, and that's your therapeutic window. And for conventional chemotherapies, that's felt to be a very narrow window. But for antibody drug conjugates, because of this theoretical way that the chemotherapy is really being delivered to the toxic with very little getting anywhere else, we would envision that therapeutic index is higher. And you can see from this lower graph here that there's a number of drugs paired with its parent sort of their chemotherapy compound. So TDM1 is associated, for example, with a maytansine analog called entansine. TDXD and sacituzumab govitecan, the parental compounds are things we call topo-1 isomerase inhibitors. And what you can see from these studies of either the ADC or the chemotherapy, in general, the drugs that are part of the chemotherapy complex as part of an ADC work better than the chemotherapy by themselves. Okay, that's been a given. But what's interesting is when we looked at this, the maximally tolerated drug of the free drug is about the same as the maximally tolerated dose of the antibody drug conjugate in terms of how much we're delivering. So for reasons we don't understand, the ADCs are not actually getting more drug to target. They just won't work better. So there's some mystery here that's not resolved. And you can see that in this graphic on the right, looking at the recommended phase 2 dosing at the MTD, the response of free drug is far less than what we're seeing in the response of antibody drug conjugates when the drug is being delivered by an antibody. This is a perplexing mystery. So why might this be? Well, it turns out there's another concept here, which is the linker itself. And we tend to think of this as a two-body problem. You have the antibody and then the drug, but the linker actually has a lot to do with this. And so a lot of companies have invested in their linker technology, and they highlight how their linker is different than anybody else's. It's to just kind of blow them off, but there's actually some weight and value to this. So if you can imagine, the linker has two connection points. One is to the antibody and one is to the drug. And it turns out you can cleave at one or both of those places to generate your drug. And so on the top, you're looking at drugs where the linker is broken between the chemotherapy drug and the antibody. So basically, the antibody is still stuck with the linker. And you see a number of drugs that have been approved and how generally they're considered unstable, going from left to right. So trastuzumab emtansine, gemtuzumab, inotuzumab, and marvetuximab, all of those drugs are relatively 50% stable-ish. But interestingly, sacituzumab govitecan, an FDA-approved drug, when cleaved, not only cleaves at the site of the drug to the linker, but also to the linker to the drug. So all the pieces fall apart with this drug. I'm just commenting on this. On the bottom, you're looking at the other scenario where these are drugs where the drug is still attached to the linker and the antibody is now free. And it's interesting that some of these drugs, what happens is that linker then recombines with albumin covalently in some cases. And so the drug is actually not just the free drug, but it's the linker and the free drug that's albumin bound. And as a result, retained in circulation far longer, both within the tumor microenvironment, but also in the peripheral blood. So these drugs don't leave your body as quickly. So they're very different in that regard. So this is just to highlight what happens to sacituzumab govitecan. You inject it, and essentially within a few days, few hours really, most of the drug is unconjugated, floating around, and you've essentially just delivered chemotherapy, and you hope you've delivered enough of that inside the tumor microenvironment. The drug is getting cleared very quickly. This is why sacituzumab govitecan can be given on a day 1/8 schedule every 3 weeks. We can kind of just pound away because most of the drug is gone. Compare that to TDXT, where once the drug is entered the system, A, it's not unlinking as quickly, and B, when the free drug is unlinked with the albumin-bound version of it, it persists in circulation for much longer. So these drugs really do behave differently based on the linker and everything else. And then the other dirty secret is we talk about these antibodies as really being great at getting to the target. This is an older study where people looked at various different antibodies and then just the naked antibody with a radio tracer and used imaging to say how much of this antibody is actually getting to the target tissue, the cancer in other words. And interestingly, you can see from this graphic, trastuzumab, bevacizumab, lebrikizumab, all drugs, all antibodies that target various targets in cancers that are very common, about 1% or less of the antibodies actually finding its way to the target. In other words, 99% of the drug is being delivered to normal tissues or not anywhere at all. So we're not getting a lot. You can imagine if you want to really do a good job with delivery to the tumor, you want really good antibodies that get more drug inside the tumor microenvironment. Even just doubling this would potentially make a huge impact for cancer. So putting this all together in a schematic of what's going on, first of all, we're not greatly targeting the tumor. So any technology, any antibody, any way we can get more drug to the tumor may increase the effectiveness. And then these linker instabilities really do have a role to play within the tumor environment, but also within the circulation, and those dynamics can differ. So when we look at these drugs, you're like, oh yeah, it's just another TROP2 drug that targets a topoisomerase into a cancer that's this thing on it. There's so many variables there that many of these drugs may not be doing the same thing, even though on the surface of it, they look like they're kind of carbon copies of each other. They're really not. So to answer the question, why so many ADCs, it's well, because we don't know how they work. So we'll sort of move forward with that premise and kind of walk you through the history of ADCs now. So I'll start with ancient history. This is before 2020. The first drug on that was ever evaluated as an ADC is this drug, gemtuzumab ozogamicin, or Gemzart. This is a drug that I actually knew all the founders. And the first doctor who ever gave the drug to a patient is Eric Sievers, a colleague and friend of mine from the Hutch. And this is for AML first relapse. And what you see is a number of patients achieving CR who previously were not able to get CR. This is back, quote, in the dark ages. We didn't have a lot for these patients. And once they were out of CR and relapse, they didn't quite do well. They were not transplant eligible. These were poor outcomes for these patients. So this was an impact that was immediately resonant for a lot of us. And this is just kind of looking at patients who got to a CR and their outcomes versus those who did not. And similarly, relapse-free survival as well. So the conclusion from this was this antibody drug conjugate called Mylotarg, sorry, I said Gemzart, I meant to say Mylotarg, to patients with CD33 positive AML in first relapse induces complete remission in what appears to be a favorable safety profile. So that's a direct quote from the paper in JCO. However, when they did the phase 3 study, what I just showed you was a phase 1/2 study. When they did the phase 3 study, they saw that they didn't see that kind of benefit. And in fact, there was a trend initially showing that the patients who got Mylotarg actually did poorer and because of toxicities. Bottom line, this is a negative trial, and it set everybody back quite a bit. And this is the relapse-free survival from complete response, all patients. You're just really not seeing any differences here. And when they looked at toxicities, the toxicities were actually worse at a higher grade in non-hematologic as well as hematologic for patients who received Mylotarg. So not only did it not work, it was less safe. And so this kind of set everybody back. The PI of this study was Stephen Petersdorf, who I considered to be my mentor when I was in a trainee as a fellow. But what happened is people said, well, maybe we're just not giving this at the right schedule. They went back and figured out a safer way to give it to patients with a better schedule. And as a result, this positive phase 3 study was conducted, and you can see the results here showing an overall survival benefit for patients given Mylotarg. And then, they didn't really identify any subgroups that didn't benefit from it, and it was also more safe. So this is the tortured story of this particular hero. In 2000, we get this first sort of hint, It gets approved, and then it gets pulled by the company for the failure in the phase 3 studies. It was rehabbed and given again in a handful of studies, I think 4 in total, and all of those were positive trials. And then they were resubmitted to the regulatory agencies, first in Europe and then later in the United States. And it's now an agent available in 2020. So 20 years of kind of rolling around, hoping for this drug to find a place, a footing in cancer therapy. And it finally did. So that was the first drug. And just a personal story, I was in Seattle at the time, and there was a company many of you might have heard called Seattle Genetics, later called Seagen, later acquired by Pfizer. My first job offer was actually from them, and I made the foolhardy decision to say, well, I think I'm going to be an academic physician. But bottom line, that the drug that they were trying to recruit me to kind of work on is this drug called brentuximab vedotin, which is being developed for Hodgkin's disease. This is just the schema of that first trial that was published and presented in Lancet, a phase 3 study, a very positive trial for brentuximab vedotin in patients with Hodgkin's disease. And once incorporated now in subsequent studies into chemotherapy, chemotherapy-free regimens, et cetera, it is essentially the standard of care for this disease, as well as a particular T-cell lymphoma. And in general, very well tolerated with the exception of neuropathy rates, which are a little bit higher, and that's really related to the free payload as it enters nerve tissue. So that's the Hodgkin's lymphoma story, which really set the stage. But around that same time and concurrent with that, other companies were developing these assets for other diseases. And the first of those was this drug TDM1 or trastuzumab emtansine. So this drug was in the study called the Amelia trial, was compared for patients who had a prior line of therapy with HER2 positive disease containing trastuzumab-based, chemotherapy-based therapy for their first line. And if they progressed, they were in theory eligible for this study. The comparator arm was a small tyrosine kinase inhibitor combined with chemotherapy, lapatinib and capecitabine. And you can see here the single agent, well-tolerated drug has a 35% improvement in progression-free survival based on this hazard ratio, an improvement of 9.6 versus 6.4 months. This was the standard of care until quite recently. And this is the overall survival benefit noted in that 31 months versus 25 months. And just to reflect on when I started breast cancer and was taking care of patients with HER2 positive metastatic disease, the quote I would often have to share with patients is, I can expect to keep you alive for about a median of 6 months. This drug plus the first line therapy, which is now called Cleopatra, has now pushed this out to 55, 60 months, and we're still improving on that. So these drugs are really important for our patients. So interestingly, that study I just showed you was in the metastatic setting. And the question is, if it works well in the metastatic setting, is there a place we can incorporate an antibody drug conjugate in the adjuvant setting, in the early stage curative setting? So this is the first, in the solid tumor space, this is the first trial to show that. So this is a study called the Catherine trial. This is a trial in which patients who had HER2 positive breast cancer were given preoperative therapy. And if they did not achieve a complete response, historically what we did for these patients is we just gave them more therapeutic antibodies and hoped that they didn't recur, knowing that an unacceptably high fraction would, 20% of patients would recur in this setting. So the idea was to, rather than give them the same, maybe we give them this antibody drug conjugate, which after all works well in the metastatic setting. And so this trial looked at a randomization of just maintaining trastuzumab versus switching to TDM1 to essentially complete out 1 year of care. And you can see immediately a 50% improvement in the hazard ratio. You go from about 80% to 90% in terms of disease-free survival. And then freedom from distant recurrence was the main event driving these benefits. And then the well-tolerated with the safety profile that essentially was very similar to what we expect in the metastatic setting being observed. Interestingly, a lot of patients still discontinued the TDM1, and somehow it's harder to do in the adjuvant setting than the metastatic setting. But regardless, this is the outcomes of this study. So quite recently, earlier this year, we got the New England Journal update on the Catherine study showing not only is this trial continuing to show benefit as we monitor these patients later, still now a 13% difference, 14% difference in terms of the disease-free survival. There's now the emergence of an overall survival benefit. So 1 in 20 patients is literally living because this drug was given to them in the adjuvant setting. This is a huge number, especially when you think about the burden of breast cancer in the United States. So that's kind of a history, where we've been with the simple first tools we had TDM1, we had brentuximab vedotin, what are all really early phase, phase 1, phase 2 agents in terms of just where they are in the development track. But we've been in the laboratory. We've been developing better linkers, better payloads, and better antibodies for that matter. So what does it look like now? I'm going to mostly focus now on some of the updates in breast cancer, but some of these agents are actually approved, and we expect approval in other diseases like lung cancer and so forth. So HER2 positive breast cancer, again, we've talked about that a little bit. This is the paradigm that exists today. It's probably going to change by the end of the year, early next year. But you have in the first line something called the Cleopatra regimen, chemotherapy plus dual antibody therapy. And in the second line, you have this antibody drug conjugate called TDXD, trastuzumab deruxtecan, trastuzumab targeting HER2, deruxtecan, a topo-1 isomerase payload that has the linker still attached to the drug, therefore persists in the circulation a little bit longer. And then other ADCs like TDM1 having moved down lines of therapy as well as other chemotherapies. So that's what we've been doing. So how did we get here? So as I mentioned earlier, in the metastatic setting based on the Amelia trial, TDM1 is now the standard line, second line therapy for patients with metastatic HER2 positive breast cancer. So the simple experiment is, can we give TDXD, which we now know to be a very active agent in much later lines of therapy, can we give that in the second line and sort of unseat the current second line therapy, which is TDM1? So this is just to show you the distribution of patients, distribution of exposures, et cetera. Interestingly, this patient population, even though this is a global trial, still looked a lot like what we might see in the United States, so relevant to our practice in the United States. And this is the main top line result. The PFS was dramatically improved. There were 23 zeros in this p-value. The last time we saw 23 zeros in a p-value, does anybody know which trial gave us that? Is when somebody stumbled on adding rituximab to CHOP. We don't see this very often, so this is a very robust finding. The median progression-free survival was not reached for TDXD. It was 6.8 months for TDM1. The rate of 12 months progression-free survival is 76%, so pretty dramatic results. I have patients who have been on this drug for much longer as well. There was no subgroup pre-specified that did not benefit. I call these little things TIE fighters from Star Wars. You can see the TIE fighters all far left to the left of the line of unity. And in addition, they are very narrow wingspan. So these are very tight estimates. There was really no group that did not benefit. And then we have a signal for overall survival. OS medians were not reached for either group, just reflecting the overall good outcomes that HER2 positive breast cancers, even in the metastatic setting, might enjoy. But there is an emergence of a difference that now continues to be sustained. This trials continue to be monitored, and I only expect that hazard ratio to stay stable, 0.55 right now. And these are active drugs. So this is the waterfall plot in a metastatic trial. There are just an enormous number of patients who we have what we call complete responses. And when you combine the partial responses to complete responses as well as the stable disease, those whose cancers are not worse by 20% or not better by 30%, stable, nearly every patient fell in that group. Only 2% of the patients were primary progressors on this study for the investigational arm. So it's a very active drug. And then in terms of toxicity, and I'll spend a little time on this drug a little bit later in terms of toxicity, but no new safety signals as we've moved it up. In fact, we got better as doctors managing these toxicities such that patients were able to sustainably be on the drug longer, and in particular, avoid serious complications such as interstitial pneumonitis, a very well-known and dangerous complication of this drug. One other funny dogma that's been challenged is when we give drugs like therapeutic antibodies, we don't actually expect them to cross the blood-brain barrier. We've known that for a while, and in order for us to even see meaningful quantities, we have to give a lot of the drug in order to systemically to get and force enough of the therapeutic antibodies into the CNS. We didn't know the situation around antibody drug conjugates and their access to the CNS. So I'll step back a minute and say, well, there is something called the blood-brain barrier, but there's also something called the blood-tumor-brain barrier, right? So tumor cells and tumor barriers are different than blood-brain barrier. They're more faulty, leaky, et cetera. So there's a possibility drugs get in there. So it was a reasonable question to ask, can an ADC have a role to play in patients with brain metastases? I won't share it with you, but there was a prior experience looking at the earlier phases of studies and combining patients with a known history of brain mets and just asking what their experience was. And it looked like this drug, TDXD, was providing value to these patients in terms of protecting them from progression within the CNS, but even the observation that some patients were receiving and achieving intracranial responses. So this is a phase 4 study, post-marketing study, where they had two arms. They had an arm of patients with no history of brain metastases, and then they had an arm with brain metastases that were untreated in many cases, and asked the question, how good is this drug in managing that scenario? So there is no comparator arm really. This is a single arm phase 4 study with two arms. They're not to be compared. Statistical nonsense. But anyway, the probability of PFS in the patients overall was 62%. And the patient's OS was at 12 months was 90%. Patients with active brain metastases, in which 90% of the patients are still alive at 12 months. When they focused specifically on the PFS in the central nervous system, the CNS PFS at 12 months was 59%. And then these are the responses that you're seeing inside the central nervous system. So we're now seeing for the first time with a therapeutic antibody confirmed complete responses in the central nervous system, something we'd really only seen with small molecule inhibitors and definitely not at that rate of benefit. So these are very active drugs inside the central nervous system. In addition, one of the hardest diseases to manage for medical oncologists is something called leptomeningeal disease. That's when the cancer spreads along the meninges. It's a horrific, horrible way to pass. And these patients have typically lived on the order of weeks, if not a few months. So very unmet need. And most trials, interestingly, exclude patients with leptomeningeal disease from participation. So there's a trial called the DEBRA trial that has multiple cohorts exploring the role of TDXD in a variety of settings. And one of those cohorts, cohort 5, was a leptomeningeal patient cohort. There was only 7 patients on the study that met endpoints, but essentially the median OS was 13 months. Again, this is probably 6-7 times greater than we would typically expect from these patients. And moreover, patients really did not progress in the central nervous system. In fact, the patients that succumb to their disease outside of the CNS. So this is also a very active agent potentially in this setting. So an antibody drug conjugate doing things we'd never imagined it could do. So yeah, that's the point I just made. So this is now from ASCO 2025. This is one of the big readouts. In fact, it got its own morning, 7:30 in the morning, and we all climbed into our cars or whatever and got there and watched it, and then kind of processed it. I was asked to speak immediately on it as basically as soon as it came out, but I've since been able to simmer on it and think about it a lot. So this is a study which is now attempting to move the drug TDXD into the first-line therapy space for HER2-positive disease. Again, just to remind everybody, in that space right now, we have a drug combination of a taxane chemotherapy given as an induction in combination with dual antibody therapy, pertuzumab, trastuzumab, and then those patients stay on pertuzumab, trastuzumab until progression typically. So that's what we call THP. There are 2 comparator arms. There's an arm where people got TDXD plus pertuzumab, so a HER3 targeting antibody antibody combined with TDXD, and then TDXD from placebo. I will tell you the first arm has not been reported. The events are immature, and so we don't have this. And as a result, what we saw was just what we call an interim analysis combining or comparing arm 2 and 3 here. So that's what I'll present today, PFS related to that and some other secondary outcomes as well. So in terms of the number of patients screened, et cetera, we're left with roughly 380 or so patients in both of these arms. And you can see the reason why they discontinued therapy is different because of the progressive disease. Remember, taxanes in the comparator arm was used as an induction. So most of those patients discontinued not because they were progressing, but because the investigators felt that's enough of that. Let's just give you the therapeutic antibody. Whereas when it comes to TDXD, interestingly, only 21% of the patients discontinued for progressive disease, but overall 60% of the patients discontinued, meaning it became too hard to give for a large number of patients because it is a tough drug to be on over the long haul. Just a breakout, and bring this up because this is problematic. This is a trial that was quite global. The agent initially developed by a Japanese company, large Asian representation on this population. Usually when you see demographic tables published in the United States, it will say this many patients from this country. This one just says Western Europe and North America, it's only 23%. And so you can imagine population of patients we might see in Chicago deeply underrepresented on this study. So that is something that we do need to dive into. But in general, good performance status. Patients typically had robust HER3 expression. Another kind of funny thing here in the study is in the United States, typically we see a higher proportion of patients who have hormone receptor HER2 positive disease. Here it's split 50-50, so a little bit different. And then another thing that's different in the United States is most of our patients are presenting to clinic with metastatic disease after previously having had a diagnosis of early stage breast cancer. Here, 50% of the patients are presenting with de novo stage 4 disease, so a little bit different as well. And that's important because they're not as exposed to prior therapies and may perform differently on this study. So all of this is to say, yeah, this is a great study. It's carefully randomized and controlled, but the population of patients really does look different than what we see in the United States. Just a subtle critique here. And these are the prior exposures and reflective again that this is not a US-based study, but more a global study. A lot of these drugs, for example, pertuzumab in the United States would be a much higher use than we see here, as well as some of these other drugs. Anyway, regardless, this is an incredibly positive study. So first off, the median PFS for the investigational arm is 41 months, hazard ratio of 0.5. And interestingly, that THP is 21 months. That's better than what we saw in the Cleopatra trial by a meaningful amount, almost 4 months better. So my takeaway from that is that we're just really good, better doctors than we used to be. It's a joke. But anyway, it's probably more reflective of the de novo metastatic nature of most of the patients on this study, meaning we expect to see better responses even in the control arm. But regardless, a very wide difference between these two arms, even at the restricted means points. And then in terms of objective responses, interestingly, we see about 70% both categories, but the quality and the depth of the responses are probably better in the TDXD arm. In addition, we see about 15% of patients getting to a point where they have no evidence of disease, compared to only 7% in the, 8.5% in the group that got THP. So a possibility that more patients are being pushed into the curative setting. And then the duration of response, again, much longer with TDXD plus pertuzumab versus THP. And this is the OS. It's still very, very immature. There's a trend here, is what people call it, about a 16% improvement. This may be difficult to show long-term just because of crossover in the real world, but we'll continue to track this data. And then in terms of other treatment emergent adverse effects, you're seeing a slight higher rate in the TDXD arm, but keep in mind, these patients discontinued chemotherapy oftentimes much earlier, so they just weren't on the drug long enough on the control arm to accrue as many side effects as you might expect with TDXD. And this is just a range. This drug does cause quite a bit of nausea, and as a result, it has an NCCN recommendation as highly emetogenic chemotherapy, and you can get quite a number of agents approved and given for these patients to manage that. Part and parcel of that is quite a bit of fatigue. Most of the chemotherapy-like toxicities, remember, are short-lived for the patients on the control arm. So quality of life, even though they're responding to drug well, a quality of life that is probably, to be accurate, less good than what you got with the comparator arm. And ILD rates, again, we had 2 patients die from grade 5 pneumonitis. I've since gotten clarification from the investigator who's on the study that 1 patient developed ILD and refused treatment for the ILD and passed as a result. And another patient had sort of a similar, not refusing therapy, but kind of an unrelated phenomenon related to it. So we're not 100% sure that these are purely related to unmanaged or mismanaged ILD. And the other funny thing was a higher rate of LV dysfunction, which is something we see with HER2 targeting drugs, 11% versus 7%. So that was the ADCs that, in terms of TDXD, a cool new drug. It's got footing now, not just in breast cancer, it's got an indication in lung cancer and other cancers as well. And with potential to see its use broaden, not just in the metastatic setting, but early stage setting. It's a very important drug, but really licensed the way for others to think about other assets. Along the same time as TDXD was being developed, another drug was being developed called sacituzumab govitecan. Again, this was presented at this ASCO and is a immediately practice-changing article in my view. So this is in the first-line setting where we typically give chemotherapy plus checkpoint inhibitor for patients whose cancers express PD-1 at a particular level. This is now looking at that same population, but offering them a randomization to sacituzumab govitecan plus pembrolizumab versus standard chemo plus pembrolizumab. And the primary outcome is PFS. So this is an unmet need population. Patients with TNBC don't do well, even with great new drugs. So when we look at this trial, well matched, here we actually still have a problematic enrollment of Black patients, but this trial was less globalized than others. There was quite a bit of enrollment sites in the United States, including our own center. And this is the top line data, 35% improvement in the hazard ratio, median PFS of 11 months versus 8 months. And then there was really no subgroup that did not benefit from this. There were smaller groups that have wide confidence intervals, but in general, this is across the board in pre-specified subgroups effective. And then the OS is still quite immature, but again, trending in the right direction, 11% improvement here. And then toxicity is not different from what we expect. This drug is given day 1-8, and remember the payload is essentially irinotecan, and that is a drug that is associated with neutropenia, and we see quite a bit of that with this. We do have growth factor prophylaxis available for these patients to make it feasible. And so this is, even though an acknowledged problem, something that medical oncologists can overcome without too much difficulty. And just in terms of duration of therapy, higher with SG Pembro, meaning patients weren't falling off even though they were responding. And then the TREs and other reasons for discontinuation, not very different between the two arms. And then lastly, you know, I focused mostly on HER2 positive disease. I've focused a little bit on TROP2 targeting antibody drug conjugate in the way of sacituzumab govitecan. But the HER2 family, I want to go back to it as well, because this is a family that we know can be a driver. When HER2 is overexpressed and it partners with its binding partners, either another molecule of HER2 or other EGFR receptors. But what we typically have focused on is that far right from your perspective image of 3+ staining. Dense circumferential staining is HER2 positive disease. But we've known for years where even when HER2 is not a driver, it can be expressed at smaller quantities in tumors. And is enough of that, is that enough to get an antibody drug conjugate to be effective? So pretty decent question. We've known from prior experiences that first generation drugs like TDM1 were not effective in that lower expression group. But if you've got bystander killing, a more potent payload, a better targeting, you know, into the tumor microenvironment, a retention of the chemotherapy within the tumor microenvironment, maybe we can start to rethink whether or not we can get this lower level of expression. And this is to show you that trastuzumab deruxtecan, for example, has entered this space. This is in patients with hormone receptor positive metastatic cancer, and this is in patients with triple negative breast cancers that express scant amounts of HER2. So it's been acknowledged by the NCCN based on recent clinical trial data. So this is a study, I'm just going to touch on it briefly, on HER2 low and ER positive disease primarily. This is Destiny Breast 04, again looking at TDXD. And what we show in the HER2 low population is this randomized study. Most of the patients you can see are hormone receptor positive, but they snuck in a few triple negative patients as well, compared to standard of care chemotherapy on patients who had seen a prior line of chemotherapy in the endocrine setting. And again, very positive trial, 10 months versus 5 months for the median PFS. And then this is all the patients, including the triple negative patients, really not that different when you tossed in those patients into the mix. And this is the OS, another positive value, both for the hormone receptor positive patients as well as the combined with the hormone receptor positive and triple negatives. And then very active drug compared to regular chemotherapy with a higher rate of responses, including some CRs. Unfortunately, toxicity signals that were not that different. So this is a little old, 2022. But what we had, well, I'm going to present one more trial related to that in a minute, but real quickly, just we now have these 3 big studies and in terms of ILD from this agent, and you can see over time, we've really learned to manage and mitigate this toxicity. And even if it happens, we have better guidance on what to do. We have guidelines on how we manage this. We involve our pulmonologists, we give steroids. If it's grade 2 or worse, we stop therapy and discontinue it. If it's grade 1, we can re-challenge. So we have worked out all the kinks on how to do this. So we've become more aggressive about identifying and pushing this drug into patients that may have not been considered before in terms of expanding the pool of patients. And so this is the Destiny Breast 06 study, where we now move this in the hormone receptor positive HER2 low setting, and now also bring in an entity called HER2 ultra low. So these are tumors that our pathologists would stain as 0 staining, but we see scant amounts of HER2 signal inside the tumor microenvironment. When you combine these two groups together, we're now capturing about 85% of all hormone receptor positive patients. And in addition, this is a patient cohort that had seen no chemotherapy in the metastatic setting. So as soon as they are no longer responding to endocrine therapy, they're jumping into this drug as opposed to a standard chemotherapy, typically capecitabine in the comparator arm. Just a distribution of patients, globalized study, very poor representation of the conventional American population. You can see the enrollment rate of Black patients is in the low single digits in all the groups. Regardless, the PFS meaningfully different, 5 months improved, and this now earlier line of therapy has a ratio of 40% improvement. And then this is in the ultra low population, really not behaving any differently than the low population. So in general, another drug that's very active in a space that we did not expect it. And as we kind of get better at managing the safety signals and the toxicity of these drugs, will we be able to stretch it into newer spaces? The obvious question in breast cancer, for example, with that drug is now that we've moved it up in the metastatic setting, is there a place for that drug in the adjuvant setting? And those trials are ongoing. There's a trial, for example, called Destiny Breast 05 that asks that question. So in general, these antibody drug conjugates are not just dumb drugs. They're very different than what we thought they were going to be. And they're mechanistically quite complex. And you see advances not just, I just shared mostly stories in breast cancer in the solid tumor space, but an equal number of positive stories emerge in the liquid tumors as well. And then they have emerging roles in places like early breast cancer, the adjuvant setting, maybe in lung cancer, for example, but there's also emerging roles in places we never thought drugs would work. So for example, the central nervous system and leptomeningeal disease. And even though we've mostly shown you stories of them being used as single agents, I did show you a story of being combined with chemo checkpoint therapy. There's actually interest with combining with different checkpoints, and there's new ADCs that are now being paired with dual targeting antibody drugs as well, VEGF receptors, PD-1 together, et cetera. So a lot of cool new drugs coming down the pipe that are now going to be paired with ADCs as well. Some studies will open at our own institution. And then, as always, these new drugs come with new safety signals, and we have to be cognizant that even though they sound like they're just going to the cancer, a lot of free drug is floating around, and there's toxicities that emerge, many of them chemotherapy-like, but because these drugs are able to accrue in tissues that didn't necessarily get a lot of chemotherapy delivery, we're seeing emergent new toxicities. An example is ocular toxicity. We've had one drug, for example, that was approved and essentially pulled from the market for a variety of reasons. But one of the big contributions was it was causing horrific ocular toxicity, and the company needed to sort of rework their strategy as a drug for multiple myeloma, for example. And I hope I didn't do this to you. All right, I'm happy to take questions. It's the end of the day. Should I ask my own question myself? Like, all
Yeah. Well, thank you.
People send out the post-test, the eval and certificate email in the next 24 hours, as long as you sign in. And we have our third session next week, on hematologic malignancy, sorry, it's a long day. And, so thank you so much.